Good morning, everyone, and welcome to the first session of the Tourette Association's virtual conference. I am Chelsea Tollner, Director of Outreach and Education at the Tourette Association. Thank you so much for joining us today for the newly diagnosed seminar. We first want to thank our platinum sponsors, the Warner Fund and Pharma, as well as all of our donors and supporters for making this free conference possible. To support educational programming such as this, you may visit tourette.org/donate to make a contribution today. During the session today, we would love to hear from you and include your voice in the conversation. You'll see on the right-hand side there that you can ask questions and share your thoughts in the chat box function. Because of the length of today's presentation, we do have two scheduled breaks. Our first will be from 12:30 to 12:45 Eastern Time, and our second will be from 2 p.m. to 2:15 p.m. Eastern Time. And after those time periods is when we'll answer questions. So we'll kind of collect the questions as the session goes, and then we will answer them right after each of those breaks. So it gives us time to sift through. And now I will turn it over, and it is my pleasure to introduce our presenter today, Dr. John Walkup. In addition to being a member of the Tourette Association's board, Dr. Walkup is also the head of the Pritzker Department of Psychiatry and Behavioral Health at Lurie Children's Hospital of Chicago, and a Margaret C. Osterman Professor of Psychiatry and Behavioral Science. Dr. Walkup also serves as Director of the Division of Child and Adolescent Psychiatry in the Department of Psychiatry and Behavioral Sciences at Northwestern University Feinberg School of Medicine. His scholarly activity covers three main areas of investigation. His work with movement disorders, specifically Tourette syndrome and other tic disorders, uniquely spans psychiatry, child psychiatry, and neurology. His expertise in child and adolescent psychiatry clinical trials focuses on the development and evaluation of psychopharmacological and psychosocial treatments. And lastly, he has been involved in developing and evaluating interventions to reduce the large mental health disparities facing Native American youth, specifically drug use and suicide prevention. Thank you so much for being here today, Dr. Walkup. I'll now turn it over to you.
Hey, thanks, Chelsea. Look forward to talking with you all today. Let's see here. I think I'm gonna shrink my picture so that I can talk. Just a couple of things to get started. Just some disclosures. As Chelsea mentioned, I'm on the board of the Tourette Association of America. That's an unpaid position. But I also, we've written some books about Tourette syndrome, and I get a few royalties from Guilford Press and Oxford Press. So at some point or another, if you really get excited about what we're talking about today and go buy those books, I'll make a little bit of money on the side. I think it's important to understand that when we talk about medicines today, that most of these medicines are off-label. That means that they have not been approved for use with Tourette syndrome, and the ones that have been approved for use with Tourette syndrome, I'll specifically mention. And then at various points in time, I'll talk about clinical vignettes or something like that. And I've changed some of the details to protect the confidentiality of the kids that I've taken care of over time. So this is really the focus of today's talk. We're going to march through a lot of basic information. The whole point, I think, of this discussion today is to get everybody up to speed with the latest and the greatest. And there's lots of different periods of time or history to our understanding of Tourette syndrome. And so sometimes when I talk with patients, they have ideas that are maybe 20 years old, and we've learned more about Tourette syndrome in the time. And so it's important for people to know that many of the things that are in the media, and even that some of your doctors may talk with you about, are things that may have evolved over time. And so today's information is really going to be the latest and the greatest. So right off the bat, I talk about Tourette syndrome, and I don't include the S, but there are people who include the S as Tourette syndrome. The diagnostic manual that we use in medicine is called DSM-5, and there it's called Tourette's disorder. But the original syndrome was called Guy de la Tourette syndrome, and this is a picture of Guy here. The diagnosis is really pretty simple. For Tourette disorder, you have to have motor and vocal tics, and you have to have them more than a year since first tics onset. And you don't necessarily have to have any impairment with them. Many people, particularly some adults with Tourette, have motor and vocal tics. They've had them for many years, but they're highly functional individuals doing extremely well and don't really experience any impairment. That said, they may be uncomfortable. They may wish that they don't have tics, but their function isn't impaired. I think the other thing that's important to understand is about 2/3 of patients are self-diagnosed. That is, they've read something in the newspaper, they've seen something on television, or they've heard something from a friend or neighbor who have noticed their kid ticking, and someone has said something to them, and they've gone on the net and figured it out. I think the point of that is that many doctors are less sophisticated about Tourette syndrome than patients are who have self-diagnosed and gone to the internet and learned a lot. The other big chronic tic disorder is called chronic motor or vocal tic disorder. And that's really when someone just has motor tics or vocal tics, and they've had them for more than a year since first tic onset. And since many kids now are recognized with tics for over a short period of time, we have this thing called provisional tic disorder. What that means is that the child has motor or vocal tics, and they've been around, but they haven't been around a full year. The reason we create this provisional tic disorder is that there are many kids, about 25% of kids, who will have tics for a very short period of time, sometime during childhood. They will come, they will present, and they will go away. And so we really don't want to give those kids a full-fledged diagnosis, but we do want to recognize that if they start having tics and they've had them for 3 or 4 months, there's a chance that they'll go away, but there's also a chance that they'll persist and become more chronic. Just a couple of pieces of history here. Guy de la Tourette was working in the late 1800s, and he was working with Sigmund Freud and Charcot. And Charcot was a French neurologist who was very interested in movement problems. And all of the patients that later got the moniker of Tourette syndrome were being seen by Charcot and his student Tourette. And so Charcot said to Tourette, work them up and write up a paper describing your patients, and we'll name the syndrome after you. And so essentially that's what happened in the late 1800s. That was about the time when Freud was beginning to do his magic and thinking about dream interpretation and free association and doing psychotherapy. And so all of the patients, because there was really no treatment at that time from a neurologic point of view, all those patients went to Freud. And so really from the late 1800s until the 1960s, this was considered a psychological condition. In the 1960s, the French and then neurologists here in the United States began to use antipsychotic medications and found that medicines like Haldol were very effective at reducing tic severity. And in a relatively short period of time, Tourette syndrome transformed from a psychological condition to a neurological condition. Interesting, once there's a treatment, it's amazing what happens in medicine. There's advocacy, there's research, there's outreach. And so essentially what happens is the recognition of the condition begins to increase quite dramatically. So in the early 1960s, there were only about 100 cases reported in the entire world literature. But after the treatment got identified, more and more patients were identified and came to care. Oliver Sacks, who's a very famous neurologist in New York City, has written in some of his books about his training in neurology and how he would hear about Tourette syndrome, but then he would walk the streets of New York or be on the subway, and he would see many, many, many people with tic disorders, and really shift the focus from it being a rare condition to something that was extremely common. The other thing that began to happen is we began to see not just adults with Tourette, but kids with Tourette. And interesting, in those encounters with kids, we would oftentimes see the kid having tics, but we would look at one of the parents, more often than not the dad, and the dad would have tics too. And so we began to think, and this is more in the 1980s, began to think about Tourette syndrome as genetic, and began to do twin studies that suggested that identical twins were commonly both affected with Tourette, whereas non-identical twins weren't both affected. And we also began to see within the twin studies that there was a difference in severity between the twins. So even though they shared the same genetic material, they oftentimes had different levels of tic syndrome severity, suggesting that the environment was really important in kind of tic severity, maybe not in the presentation of tics, but in actual tic severity. And then in 2010, the first big studies of behavioral treatment, we now call that the comprehensive behavioral intervention for tics, that first presented where we really discovered on some level that behavioral strategies and working with the environment that we can actually reduce tic severity without using medicine. So we've come to a very complicated understanding of Tourette, from a neurologic condition to a neurologic genetic condition, but also a condition that is highly responsive to the environment and where behavioral treatments can actually be very effective. As a matter of fact, the Association of Neurologists here in the United States have actually said that behavioral treatment is the first line treatment for tic disorders. So these changing conceptions from it being a psychological disorder to a brain disorder, and now that we have behavioral treatments, we have a whole brand new language to learn and a way of thinking about Tourette that is really part of today's talk. Really trying to understand the role of the environment in tic severity, how tics are really worsened through interaction and through behavioral processes, and as a result of that, being able to improve treatment outcomes because of our understanding of how sensitive tics are to the environment. So just to you'll see this slide again a little bit later in the day here. But we know that tics worsen with both excitement and stress. So kids will tic more before a test, but they'll also tic more when they go to Disneyland, for example. The excitement of Disneyland can oftentimes be some of the worst experience for kids with tic disorders, because when they get excited, their tics really increase pretty dramatically. They also tic more when they get tired. If you pay attention and point tics out to kids, look at them and ask them about them, paying attention, tics will get worse with that. And we've also really come to understand that if kids are given permission to tic, that support on some level actually makes tics worse. So what we're trying to do increasingly from a behavioral point of view is keep kids involved in calm, focused activities as much as possible. Train them how to do deep relaxation, whether that's mindfulness or meditation or biofeedback or whatever. We want kids to really learn how to put their brain in that zone. And we also want them to begin to think about managing their tics in challenging environments so that they actually experience less distress and less impairment associated with that. All of what we've done in terms of understanding the behavioral approach to tics really mimics on what adults have told us about their experience with behavioral strategies. The difference is that many adults learn these strategies on their own, but what we're doing now as part of a routine treatment is we're training kids how to do the kinds of things that adults have used for years to manage their tic severity so they can function better. So, as I mentioned, adults use a variety of behavioral strategies. We really understand that there are things that trigger tics, and there are things that provide consequences that allow tics to persist over time. We can use behavioral strategies to reduce tic severities, and this makes total sense because the brain is a living organism. It can learn, and it can grow, and it can be impacted by our thoughts and feelings and by our environments. The other thing that we've come to understand is that there are ways that tics can be reinforced, if you will, in the environment. And so we are working very hard when we first meet a young person with tics to talk with their friends, family, relatives about how to interact with the child so that they don't inadvertently reinforce or worsen tic severity through their interactions. So as you know, Tourette starts in young children. This is a graph from many, many years ago, and it's still true today. Notice here that the peak in onset is really in that 4, 5, 6, 7, 8 age range. And as kids move into puberty, the frequency that with which tics first present really decreases pretty dramatically. This will be important because there's a new group of kids who are presenting with movement problems in their teenage years, and I think it's important for you to understand that the true tic disorders present during this childhood period, not later in adolescence. It usually starts with motor tics and then progresses to vocal tics. It starts in the head and the face and then moves to the body. Starts with simple tics and then moves to more complex. And the peak severity is in the early to mid-teens. Actually, what it is it's around 10, 11, 12 when kids actually have their worsening, and then as they move into adolescence, by mid to late adolescence, the tics begin to decrease. This is just about tics, so it's important to understand that we're not talking about ADHD or some of the comorbid issues that occur with tics, but I think it's important to understand when tics actually peak in severity, and importantly, knowing the life course, and that is that tics tend to get better over time. So as I mentioned, the comorbid conditions usually present later, except for ADHD. ADHD starts between 4 and 7 years of age generally, but some of the other comorbid conditions can present after tic onset. So like anxiety and depression oftentimes happen after tics have been around for a while. And I think it's also important in reassuring families to understand that the vast majority of kids with tics do well and aren't substantively impaired by the tics themselves. It's usually the other conditions that really cause kids the most challenge. So there's a differential diagnosis. Actually, tics are very easy to recognize and to diagnose. It isn't challenging. So the variety of conditions that are described here on the neurologic side are really quite distinct and different, and most neurologists have no trouble differentiating tics from these other movement problems. Psychiatric disorders, the issue here is not so much that it's hard to distinguish tics from compulsions or stereotypies or other kinds of behaviors that we see in kids, but the language that gets used in psychiatry is sometimes messy, and so sometimes you'll hear people talk about a tic as a compulsion, or talk about a tic as some kind of perseverative behavior, or a habit or a mannerism. And so sometimes it gets confusing simply because people use the wrong word to describe a tic. As I mentioned, in the 1960s, there were very few cases. Now what we have is about 1% of kids will have Tourette syndrome. And tics themselves will occur in about 25% of school-aged children. And again, the thing that's really changed is much, much more awareness. We're focusing on kids with milder symptoms, and we do diagnose those people who have tics but aren't necessarily impaired by them. As I mentioned, it's a genetic condition, and we learned that from looking at twin studies, which I just mentioned. Remember, identical twins, both twins are more commonly affected than non-identical twins. And we've also looked at family studies to see how it traces through the family. And we look at the pattern of inheritance. And initially we thought that this was a condition that went from one parent to the next. But I think we understand more and more now that it's a much more complicated process. There's likely multiple genes involved. And importantly, that it's not just the genes that are involved, but it's also the environment that impacts the development and severity of tics. So families will often ask me about, this is genetic, so what's the risk for having a child with Tourette? Because I have Tourette. And I think this question oftentimes misses a very important point, and that is, what do parents really need to know to prepare themselves to have a child with Tourette syndrome? And what I'm going to talk about in the next couple of slides really isn't genetic counseling, but it gives you a bit of a perspective about how to think about, if you're a young family and you have a child with Tourette syndrome, how to think about having other kids and about kind of moving forward in general. So probably the most important thing to understand is the vast majority of kids with tics do well. And by the time they get into their teenage years, their tics decrease. Um, the genetic risk for Tourette is not the same as the risk for a poor lifelong outcome, because again, many people will have the genetic risk factors and may not ever have any tics. So it is important to understand when you're talking about kind of how kids are going to do over the long term, is thinking about the tics, thinking about those co-occurring conditions like ADHD, anxiety, OCD, and other risks for poor outcome that are potentially not even genetic. So what do families need to know? Well, if you have a tic disorder and you have a child, your child has a 15 to 35% chance. If you have one child with Tourette syndrome, their sibling has a 15 to 35% chance of having a similar syndrome. But as I mentioned, there's this huge range of outcomes for Tourette, from very mild, almost invisible symptoms to more complicated tic symptoms. The most outcomes for tics are good, with mild to moderate symptoms that get better over the course of development. And as I mentioned, they peak in severity before puberty. And increasingly, there's less stigma associated with Tourette's than there has been before. It isn't perfect yet out there, but there is less stigma. So people are better accepted. They've managed it in the world a little bit better. And if you think about it, many of the people who are on the scientific advisory board and on the board of directors of Tourette are impacted by tics and have lived successful lives. The real issue is really ADHD, OCD, and anxiety, mood disorders, and the sneaky one for older adolescents and adults is really substance abuse. So when I talk with a family about what runs in their families, they're focused on the tic disorders, but I shift the focus to the presence of these other conditions, because these conditions actually can fundamentally get in the way of people living successfully. And so it's important to understand that there are genetic risks for tics, but there are also genetic risks for these other conditions. And then lastly, one of the things that all of us who work with families with Tourette understand that kids with Tourette are tough to parent. And as a result of that, sometimes they get into problems with their parents. Sometimes parents have their own difficulties. And those challenges, having parents who aren't really on top of their parenting skills and parents who have their own untreated mental health issues, those risks really are substantive for kids and really can impact kids' long-term outcomes. So what's it really look like? So it is extremely rare for kids to have a severe and protracted syndrome of Tourette. That's very uncommon. On the other hand, the risk for comorbid conditions and their association with lifelong disability, particularly if they never get treatment, much higher. Most kids with good coping and good self-control skills figure out a way to manage their tic disorders and other problems well, particularly if they get treatment for their comorbid conditions. And so what happens is those kids who are really getting engaged in treatment, whose families engage them in treatment, those kids go on to do pretty well. Even then, if they have severe tics, they end up being highly functional people with severe tics, which, as a matter of fact, isn't such a bad outcome. The biggest challenge for kids is when they have poor coping, poor self-control skills. And those issues are the biggest risk factor for lifelong disability. So in summary, when we talk about genetics, families need to see the big picture. It's not just about Tourette syndrome, it's about the comorbid condition, and it's about kind of lifestyle and parenting and those conditions that run within the family. Most importantly, from a parent advice point of view, is help your child develop good coping and self-control skills early in life, because coping and self-control skills are absolutely key to good function across the lifespan. So what are those comorbid conditions that I've just been talking about? Well, it all kind of depends upon where you look. If you look at community samples, there's a large number of kids who just have tics. They don't have any comorbid conditions. But if you look at expert clinics, most of the kids that we see in our specialty clinics have lots of challenges above and beyond their tics. And more often than not, the tics are a small piece of their problem. Even though they come to a Tourette clinic or a tic clinic, it's usually something else that kind of keeps them struggling and is the cause of their impairment. So we talk a lot about ADHD and obsessive compulsive disorder, but the anxiety disorders, particularly in prepubertal children, are extremely common. So separation anxiety, social anxiety, and a generalized pattern of worry are extremely common. Teenagers with Tourette oftentimes suffer from depression. And the other thing that can happen, in part because kids with Tourette are difficult to parent, is they can oftentimes develop behavioral control difficulties, if you will. And so they can become disruptive or oppositional. And those are behaviors that we try and directly address through kind of family work and environmental change. So since I work in an expert clinic, what I tend to do is I tend to think about what do complex cases really look like. And I'm going to march through in the next couple of slides the kind of way that kids don't get a good assessment, and talk a little bit more so that people understand kind of when it goes awry, kind of what happens. So what you have here is, I'm assuming that most kids who I see have tics, have some ADHD type symptoms, and have obsessive compulsive or repetitive behaviors. And the disorders listed in red are disorders that occur prior to puberty. So the families will come to me and they'll say, yes, I have Tourette, I got ADHD, I have some repetitive behaviors, but there's something else going on. And so these are the conditions that I usually see in complex presentations. So prior to puberty, I see separation anxiety, a fair amount of generalized worry and social anxiety. I joke with my autism colleagues that I tend to see more kids on the spectrum in the tic clinic than they see in their autism clinic, if you will, simply because kids with autism have a variety of movement problems. They can have tics, but they more often than not have stereotypies, and they will come to a tic clinic to try and figure out what those movement problems are. And as I've mentioned, kids can become disrupted. As we move into adolescence, there's a risk for major depression in the mid to late teenage years. Bipolar disorder presents in the late teenage years. Again, as I mentioned, kids with tic disorders and young adults with tic disorders are at risk for substance abuse. And, you know, just like every human being, people with tic disorders can be highly functional and have good attitudes with excellent judgment. And on the other hand, we do see some people with Tourette syndrome who, you know, really struggle with judgment and functioning. Really important to kind of think about your child and where they are, or if you're an adult listening today, kind of where you've been over your lifespan. But we know when most of these major psychiatric disorders present themselves. So we know that autism is identified between 0 and 3 years of age. ADHD we identify between 4 and 7. The anxiety disorders present between ages 6 and 12. Depression presents in the mid-teenage years. Bipolar disorder and psychosis is oftentimes in the late teens. Panic disorder, which is the adult version of the anxiety disorders, presents in the late teens, early 20s. And again, as I mentioned, disruptive behavior can happen at any point in time. So when you're thinking about your kid and you're thinking about how old they are, depending upon how old they are is really where they are in terms of potential for risk for some of these comorbid conditions. So one of the things that we see missed frequently from a diagnostic point of view is kids are diagnosed with Tourette, but the diagnostic assessment didn't go far enough. And so what happens is the diagnostician missed the anxiety disorder. Anxiety disorders are extremely common. They happen in about 8 to 12% of kids. And in some of our larger studies, the frequency of the comorbidity with tics is in the upwards of 30%. Well, the anxiety disorders really impair functioning. So it's very important for the diagnosticians to not only make the diagnosis of Tourette, but to look and see whether there's an anxiety disorder there and to treat that. Bipolar disorder is extremely rare, but it does happen. but it tends to happen later in adolescence. The other thing that we tend to see is we tend to see kids getting diagnoses of ADHD inattentive subtype, and I'll talk a little bit more about that. We also see that kids who are functioning poorly in school or in other domains of life, they get the diagnosis of ADHD when they may actually not have ADHD. And sometimes kids get the diagnosis of OCD when they don't really have OCD. So we sometimes see diagnoses missed, like the anxiety disorders or bipolar disorder, and we sometimes see kids get diagnoses that they don't really have. From an anxiety point of view, because it is probably the most common comorbidity with Tourette, it's important to differentiate between normal forms of anxiety and pathologic forms of anxiety. So normal anxiety is absolutely essential for healthy development. We would not live or survive if we weren't capable of becoming anxious. It prepares us for danger. It facilitates us looking ahead and planning. It's a terrific human emotion. It has predictable triggers. For kids, taking a test is a predictable trigger. You get anxious. Your anxiety is oftentimes proportional to whether you're prepared for that test or not. So if you've done your studying, your anxiety is going to be less. If you haven't studied or haven't studied the right stuff, your anxiety is going to be a little bit greater. But that predictable trigger and proportionate reaction is really what we expect to see with normal anxiety. That said, we see many kids who live in very, very difficult circumstances. And as a result of that, they are chronically anxious and hypersensitive, if you will. These kids aren't ill. Essentially, what they're experiencing is a normal reaction to extraordinary challenge. And so I don't see those kids as having disorders of anxiety, although they may be chronically anxious, but I see them as living in a kind of a hostile world and having an appropriate, normal, and proportional reaction to how difficult their life is. On the other hand, when I think about pathologic forms of anxiety or the anxiety disorders, interesting, the triggers are normative developmental experiences. So kids with separation anxiety have difficulty going to bed alone at night. They have difficulty being in a different room in the house. They won't do sleepovers. They won't go to camp. All of those are activities that most kids really like to do, but kids with separation anxiety don't like to do that. Kids with social anxiety, they won't raise their hand in class. They won't order food in a restaurant. They won't join a new group of friends. They're shy. They're inhibited behaviorally. And again, the kinds of things that make them anxious are the kinds of things that most children really enjoy doing. Kids with generalized worry, these are the kids who think about the future. They think about the past. They worry excessively about things that most kids could care less about, but they occupy their mind. They think about life and death. They think about the universe. They think about global warming. Even though it's important to think about global warming, these kids sometimes can't shake the idea of global warming, and it impacts their everyday functioning. So normal developmental challenges are the triggers for these anxiety disorders. As a result, these kids have excessive and often disproportionate reactions. The adults who live with anxious kids often say, I don't know why he's so upset. His brother or sister can deal with this stuff just fine, but he gets too upset by it, and we don't quite understand that. And the other thing that's important to understand is that these kids all look the same. So kids with separation, with social anxiety or generalized anxiety, they kind of all look the same, which is why we use rating scales to assess them, because within the rating scale is a set of symptoms that are common across all of these various conditions. So what do anxious kids really look like? Well, they're hypervigilant. These are kids that are chronically scanning the environment. And what they tend to do is they tend to lock on to things that are novel and new in the environment. And rather than think about them as interesting or be curious about them, they decide that anything new and different is threatening and scary. So guess what? How do they cope? Is they try to avoid those things. But because remember, they're normal developmental experiences, when they can't avoid normal developmental experiences, they sometimes melt down and they have these things called catastrophic reactions. So they regress, they melt down, they get upset, they have temper tantrums, they have explosive outbursts. And parents who are oftentimes confused by this, remember the reaction is often disproportionate to the trigger. They don't know exactly what to do. So they tend to begin to work with the child to protect them from any kind of experience that might trigger them. But because these are normal developmental experiences, the kids now are being pulled out of the normal routine of life. The parents begin to think about themselves as somewhat overprotective, and they tend to support the child's avoidance, which over the long term prevents the child from really developing really good coping and adaptation skills. So what we do in terms of treatment with kids is we help them not avoid, and we help parents not accommodate, essentially helping that child take on the challenges, again, normal developmental experiences, and become successful at facing them head on. The other thing that we tend to see with the anxiety disorders is a lot of physical symptoms. So, and it goes from top to bottom, if you will. So we see kids with tension, headache, or dizziness. Some of the kids with anxiety hyperventilate a lot, and when people hyperventilate, they get numbness or tingling in their fingertips and around their mouth. These are kids who oftentimes can't swallow pills. They worry about gagging or choking or swallowing or vomiting. During COVID-19, we're seeing a large number of these kids actually stop eating and losing weight. They get short of breath and feel very uncomfortable. Some of them actually have chest pain. Abdominal pain is extremely common. Some of these kids retain stool, and so they become constipated. Others feel the need to go to the bathroom repeatedly. They feel a kind of an anxious bladder, if you will. And so when we're trying to make the assessment of kids with anxiety, we look for problems with separation, problems with social interactions, and problems with general worry. But we also pay attention to whether they have physical complaints. The reason I spend so much time here talking about anxiety is it's probably the biggest diagnosis missed in kids with Tourette syndrome. And we know that if you don't take care of anxiety over the long haul, it really impacts kids' long-term functioning. Plus, anxiety can drive tic severity. So sometimes what you see happening is a kid gets diagnosed with Tourette, he has anxiety, the anxiety was not diagnosed, the Tourette was treated, the anxiety was not treated, but because the anxiety is there and it makes tic severity worse, the person goes after the tics, goes after the tics, goes after the tics with meds and other treatments, but they aren't very successful because the anxiety is actually making the tic symptoms worse. So a variety of other symptoms present with anxiety. Kids with anxiety disorders have difficulty falling asleep. They wake up in the middle of the night and sometimes come and visit mom and dad. I'm an anxious overeater, so when I get nervous, I tend to eat a lot, but there are some kids, as I mentioned earlier, when they get really anxious, they undereat because they worry about choking or gagging or vomiting. These are kids who avoid all kinds of normal, healthy activities like sleepovers, camp, engaging in parties, talking with safe strangers at school, that kind of thing. They need a lot of reassurance and support, particularly around those normal developmental experiences like new situations, bedtime, those kinds of things. These kids will oftentimes get diagnosed as the inattentive subtype of ADHD. But what differentiates these kids from true ADHD is that their mind is full of worry, whereas kids with ADHD, their minds are kind of empty, and as a result, they're distracted by the outside world. So when I try and sort out why a kid can't pay attention, I'm trying to figure out whether their mind is full of worry or whether their mind is kind of empty, and that's why they're struggling at school. It's not necessarily pervasive. In the sense that if a kid is living in a stress-free or a trigger-free bubble, they'll look pretty happy and they'll look pretty comfortable. The problem is that that's not sustainable over time. These kids need to live in the real world and need to learn how to cope and function. Those catastrophic reactions can turn into explosive outbursts or temper tantrums. These kids are often tired and tense at the end of the day. Most kids come home from school when they used to come home from school. and they used to go out and play or have a lot of energy and blow off steam. But kids who are anxious, when they come home, they oftentimes take to the couch and need to rest. There's a couple of odd symptoms that we sometimes see in kids with anxiety: derealization and depersonalization. Depersonalization is that experience you have where you kind of stand outside of yourself and you look at yourself and you kind of comment on who you are. And derealization is that experience when things kind of, you're overwhelmed with anxiety and you feel like things around you are kind of unreal. When kids try and explain these symptoms, when they're experiencing them to adults, they don't sound very good. They sound like they're quite disturbed. But these are simply anxiety symptoms and kids' inability to really describe these kind of complex sensations. Bipolar disorder is also something that's extremely rare but can co-occur. And I tend to think about the core criteria. I call them hallmark symptoms, and I've listed them here in color. So for bipolar disorder, I really am looking for kids who have elevated and expansive mood. I know a lot of kids with Tourette will get a bipolar diagnosis just because they're irritable or cranky. But for me, that's not enough. They actually have to be kind of over the top, if you will, in terms of their mood. They have to have big thoughts. They have to have decreased need for sleep, not inability to fall asleep, but they don't need sleep. They'll sleep 3 to 4 hours and be totally rested and have plenty of energy. And these are also kids who have what I call increased goal-directed activity. They are on the go. They are creating and building and doing all kinds of stuff, if you will, in this kind of driven. They are not inattentive. They are just focused on goal-directed activities that sometimes get them into trouble. So, as I mentioned, sometimes we overdiagnose OCD in these kids simply because there are a lot of repetitive thoughts or behaviors in kids with tic disorders. And what we've done really more recently is to develop a tic OCD subtype. And this subtype of OCD is characterized by physical sensations. So what kids will have is they'll have this feeling in their shoulder, and we call it a premonitory sensation. And what they'll do is they will move that shoulder around and kind of in a tic-like way in order to get rid of that sensation. What's different about this repetitive behavior, the sensation and the motor movement, from typical OCD is there's usually not a lot of associated distress. Kids feel the sensation and they make the motor movement. Whereas kids who worry about dirt and germs and contamination and feel like if they don't wash their hands 5 times, 10 times, that they're going to die or a relative of theirs is going to die, those kids experience a ton of distress with typical OCD. So we now have this tic OCD subtype. The other thing that's very interesting about the tic OCD subtype is it's not responsive to the medications that work for typical OCD. So sometimes what we see happening in the clinic is a kid gets a diagnosis of Tourette. He has the Tourette OCD subtype with physical sensations and repetitive motor movements. And he gets a ton of medication for OCD, even though we now know that that tic OCD subtype doesn't respond well to the medicines that typically treat OCD. I'm betting we get some questions about this in the break. So we also experience among diagnosticians a lot of symptom confusion. So as I mentioned, the feeling that people have before a tic, we call a premonitory sensation. That worry about dirt and germs that we see before people do hand washing, that's an obsession. Depressed people worry about poverty, they worry about brain damage, they worry about bowel dysfunction. These are people who are depressed, who get preoccupied with their body not working. People with psychotic disorders have delusions. Children on the spectrum will oftentimes have perseverative thoughts. They'll have an idea about one of the more interesting kids I met had a preoccupation with the concept of tall, like what's the tallest building, who's the tallest person in the room, are you taller than I am, am I taller than you are? And he got very stuck on this concept of height and tall. Occasionally in our specialty clinic, we will see kids who come in who are you ready, obsessed with marijuana. They're not really obsessed with marijuana, they crave it. So it's very important to differentiate, particularly with substance use, that those things are cravings, those are not obsessions. And we tend to see some kids who have ideas that are common in the marketplace. One of the most common, I think we're seeing now anyway, during COVID-19, is that there are kids who believe that it's great to be thin and beautiful, but we're seeing increasing numbers of kids who are beginning to starve themselves and developing anorexia nervosa. So sometimes that value of being thin and beautiful and being healthy can become overvalued and can actually drive people to pretty substantive impairment, like with anorexia nervosa. And then occasionally we see kids who have been traumatized by violence in the community and they'll have flashbacks. And again, those are intrusive thoughts, quite different than obsessions or ruminations or delusions, and are correctly described as flashbacks. So if your diagnostician is not smart about all of these different kinds of repetitive thoughts, misdiagnoses can happen, and as a result, misapplications of treatment can occur. So similarly, there are a lot of repetitive behaviors in mental health. So we talked about tics here today, talked a little bit about compulsions. The classic one is compulsive hand washing or grooming rituals. Stereotypies are the kinds of things that you see kids on the spectrum do. These are things like hand flapping. We'll talk a little bit more about that in a second. Also, perseverative behaviors. These are things that kids do over and over and over again. So autistic kids who spin the tire on the trike or repetitively flush the toilet, those are perseverative behaviors. They're not compulsions. And then really what we see people when they're using alcohol or street drugs, those are addictive behaviors. They're not compulsive behaviors, they're addiction. And we do see people with normal routines and habits. Just to take a step back and talk about stereotypies, there are some kids who actually have stereotypies too. So they have the tic disorder symptoms, but they also have stereotypies. Stereotypies are often earlier in onset, usually before the age of 3. They have a very consistent fixed pattern. They oftentimes include the hands, the arms, or the entire body. They're quite rhythmic and prolonged. And I think the most common one that we see are kids who have a kind of a flapping move. I don't know if you're able to see me now, but something like that is more of a stereotypy. It doesn't have the premonitory urge or that sensation that comes prior. It stops quickly with distraction. So if you call the kid's name, they will stop. But oftentimes, if they get back into the activity, they will quickly resume the stereotypic movement. Tics, as we mentioned, occur a little bit later. They evolve over time. It's much more in the eyes and the face and the head. It's brief. It's rapid. There is the premonitory urge, and it actually worsens with distraction. It doesn't go away. So if kids are focused and engaged, the tics go away. If they get distracted or pulled off task, you sometimes see tics actually worsen. As I mentioned, it's an involuntary, rhythmic, repetitive movement over time. It can appear purposeful, but it really has no obvious functioning. Again, it stops with distraction, and I've listed some things here like flapping and waving, bigger movements of the arms and trunks. These kids oftentimes begin to evidence these movements when they're very excited about something or they're engaged in an activity. So if they're playing a game or they're involved in some art activity and they're really enjoying themselves, you will often see them begin to have stereotypic movements. The repertoire is quite individual in the sense that the kid has a certain set of stereotypic movements that are theirs and theirs alone, if you will. They don't tend to evolve in quite the same way that tics evolve. There are some people where it's called primary. So we do see kids who have stereotypic movements who have no other developmental challenge. And then we see some kids who have these stereotypic movements where it's associated with autism or other developmental delays. As we mentioned, it starts early in the early in life. Leon Doer, a neurologist in Alabama, calls them baby movements because they happen so early in life. It's very unusual to see tics at age 2 or age 3. It does happen, but it is unusual. The vast majority of kids are unaware of these movements, and it's thought that these are really common, that 3 to 4% of school-age kids will have these stereotypic movements. The other one, the other diagnostic error is to call kids ADHD. And I think the challenge here is that kids who have a tic disorder and who may have anxiety or another comorbid condition have a million reasons to be off task. So part of a really good assessment, rather than just giving a kid an ADHD diagnosis, is to look at them and say, what's getting in the way of that kid paying attention at school? Because if your eyes are blinking and your shoulders are shrugging, it's going to be really difficult for you to pay attention, particularly if you have that premonitory sensation that occurs before the tic. You're going to get occupied. The other thing is kids will describe, once they tic in the classroom, that they get very sensitive to other kids looking at them, so their self-consciousness can get in the way of them paying attention. Children with anxiety whose minds are full of worry, they have trouble paying attention. Kids who are off task in general or disruptive, they have difficulty paying attention. And some kids will describe how much time they spend trying to suppress tics so that people don't notice them. And that takes a lot of mental effort, and that will take kids off task. So we tend to see a lot of ADHD diagnoses in kids with Tourette syndrome. And oftentimes when we get to know the kids really well, we will identify what the true reason is for them being off task. And it isn't the brain-based condition of ADHD. It's oftentimes one or another of these other kind of causes. As I mentioned, these are the age of risk. So when we're talking to a kid who's 6, 7, 8, 9, we're looking for ADHD and anxiety. And if we're talking with someone who's struggling now at 15, 16, and 17, we tend to think more about depression, bipolar disorder, and psychosis. Just more about ADHD confusion. The assessment oftentimes occurs between ages 4 and 7. But if you look at what we're looking at here, is that this group of kids right here between ages 4 and 7 are hyperactive, inattentive, and off task. And you know what? As they age, we become much clearer about what the cause is, whether it's ADHD, whether it's a learning disability, whether they have an anxiety disorder, whether they have behavior problems, whether they have depression, bipolar disorder, or personality disorders. But right here, between the ages of 4 and 7, all of these conditions up here look like ADHD between the ages of 4 and 7. So people tend to get the diagnosis of ADHD, even though they may not have the classic form or the true condition of ADHD. They may just be having early symptoms of some of these other conditions. The other challenges that we see kids developing over time is maladaptive behaviors like substance use problems. Having a kid with TS sometimes really works its way into the family in a way that's problematic for the siblings, problematic for the marriage. Anxiety, ADHD, depression, and pervasive developmental disorders or the comorbidity of tic disorders with like Asperger's or autism. The other thing we tend to see in the clinic is some families have some problematic assumptions. And we know that this is a neurologic condition that kids can't control, but sometimes what happens is we actually work with families where the tics are facilitated or elaborated or promoted, if you will. And it oftentimes comes when the families kind of give up and say, my son can't control these movements, so I'm just encouraging him to move as much as he possibly can. And what we're doing now in our behavioral treatments is really working against that idea. He can't really control it because it is a neurologic condition, but we really do want him to learn how to manage his tics and to manage the tic severity so that he can function better in this world. We see some families who feel very guilty that their kid has tics, particularly if one of the parents has tics. So they feel genetically guilty, if you will. And so they feel like they can't set limits. They feel like the youngster has a tough life, so they need to indulge him. We sometimes see kids who families really want special accommodations. They fight with school systems. There are some kids who really need special accommodations, but sometimes special accommodations are actually stigmatizing. So being careful about the help that you provide for a kid is really, really important to make sure they get the right help, but don't necessarily get stigmatized by the help that they get. Many families think that medication is the answer. Well, increasingly we're using behavioral treatments. And then sometimes families get freaked out by what they see on television or on the net, because what you tend to see there really is not representative of the typical course of Tourette syndrome. So we encourage people to check it out with their doctor or clinician and not get too upset by what they see on television or on the net. And then lastly, because Tourette is kind of a confusing condition, there's a tendency for parents to see all challenges that the kid is facing as Tourette related, when what we're trying to do is we're trying to say Tourette is mostly about movement problems, those premonitory sensations. And the big issues are really all of those comorbid conditions that oftentimes don't get diagnosed and can cause substantial impairment. So as I mentioned, it's not easy to have Tourette syndrome. It's not easy to parent a kid with Tourette syndrome. Most parents that I've worked with are quite uncertain about what's a tic, what isn't a tic, what limits they can set, what limits they can't set. Do they keep with routine parenting strategies or do they deviate from that? All of that kind of uncertainty in parenting style actually provides opportunities for kids to actually do poorly from a self-control and coping point of view. Less common now, but still common, is we see kids who, during the course of their early life, identifies Tourette syndrome as central to their identity. And in that whole process, parents de-emphasize those things that I think are truly central to identity. And those are things like, what's your biological endowment? Are you smart? Are you athletic? Are you friendly? Are you easygoing? Who are you as a person? The other part is, what kind of a family member are you? Do you contribute to the family good? Are you participating in family activities? Are you working to your capacity academically? Are you really a good, trusting friend? And can people count on you in peer relationships? Are you good at sports or athletics, or do you have a way to occupy yourself to keep your mind free and to manage yourself well and enjoy life? And importantly, are you competent in kind of taking care of yourself, managing your emotions so that you have some confidence in how you live? These are the core elements of identity, and these are the kinds of things that we are working with families to build in their children, so that the kids see Tourette as something that they have, but not something that owns them, or not something that they want to organize their identity around. We have seen some kids who organize their identities around Tourette, but then when they're 15, 16, and 17 and their tics go away, they haven't really done the other work of personality and identity development. And so when the tics are gone and they see themselves as a person who's Tourette syndrome, they're kind of cut loose, if you will, because they haven't really anchored themselves in those deep, meaningful activities that are part and parcel of a core identity. The other thing we tend to see, there may be some adults listening today, but depending upon how old you are, you may have gotten completely different treatment, and you may have been told something completely different about Tourette. So for those adults who are 40 to 70 years of age, many of those folks experienced unbelievable discrimination because of Tourette syndrome, and may have been treated very poorly with a variety of bizarre treatments. Those who are 25 to 40, many of those folks had antipsychotic medicines at high doses, and so lost a substantial portion of their childhood and adolescence because of over-medication. We're seeing a group of older adolescents and young adults who grew up without some sense that they needed to manage their tics to be effective and to find a way to live in the world. And increasingly, as with the younger group, we've really had a good impact on the field. And so we talk about tics a lot, but we really want people to focus on those comorbid conditions and those other things that are about being successful in life. And now, essentially what we're saying is you may be coming to us with tics, but you know what? Let's check out whether you got any of those comorbid conditions. Let's see where you are in terms of behavior and emotion control. And let's see whether you're really dedicated to taking on the challenge of the hand you've been dealt. And if you are ready to take on that challenge, we're ready to work with you and help you build a high quality life where you're going to be successful and you're going to feel good, but you're going to tic. Explosive anger. Anger is a really interesting emotion. The reason why people use anger a lot is because, you know what? Anger is really, really effective in interactions. It's not the best way to influence other people, but man, oh man, can it be very effective in changing how people think and feel. So in that sense, it's easily conditioned, it's easily learned. And once kids learn that explosive anger can set the stage for home life and interaction, they tend to be more angry and tend to use explosive outbursts as a way to control their interactions. It's in Tourette, it's highly associated with mood and anxiety disorders. And, it's also cultural. I think one of the things that we've learned over the past couple of years is how when we start letting people be angry and focus on their anger and expressing themselves, that we tend to see increases in rage and explosive behavior. Simply because at this point in our country anyway, we're very supportive of people expressing their anger in inappropriate, but even in inappropriate ways. So what do we do from treatment point of view? Well, I tend to break the different kinds of doctors or clinicians into lumpers and splitters. And I'll explain a little bit about what that is. But if you think about what all the challenges are with taking care of a person with Tourette syndrome, you have to think about what you're going to do about the tics to reduce tic severity. You have to think about what you're going to do about those comorbid conditions. For parents, you got to think about how you're going to raise your child with Tourette syndrome so they have a positive, powerful identity. And for adults who have had tics for a long time and may have had comorbid conditions that may or may have not gotten good treatment, they have to figure out how they're going to live with a chronic condition. So it is a complicated set of activities to think about treatment. It's not just about getting rid of the tics. There's a whole lot of other factors that come to play. So here's what the splitters do. And I will confess right off the bat that I'm a splitter. So I tend to make a list of the problems or diagnoses. I rank order them according to impairment, and I treat them in order of impairment. And I use treatments that are specific to each diagnosis or challenge, if you will. So I treat anxiety, I treat disruptive behavior with parent training. I do a variety of things to get kids functioning again based on what their problems are and what the treatments are that actually address those problems. What's interesting is there is a tendency for families when they come to a clinician for a tic disorder diagnosis to think about the tics and want the tics to go away. But what I'm trying to suggest to you is go to a tic specialist, get worked up, but make sure that you don't miss diagnoses. Make sure that you don't get overdiagnosed with things that may not actually be there or true, and that your treatment is really directly related to those things that are definitely getting in the way. And sometimes I actually recommend that instead of going to a Tourette doctor, that someone go to a specialist for anxiety or a specialist for depression, because if the anxiety or depression is really the thing that's getting in the way, tic doctors may not be the best doctor for that. You may need someone who treats anxiety and depression with expertise in order for your kid, or if you're an adult, to absolutely do your best. So for kids, these are the common things that we work on. We work on OCD, we work on behavior problems, and we work on tics. And a treatment plan for this is we'd use cognitive behavioral therapy and SSRI medications. We would do parent behavior management training for behavioral problems. And for tics, we might do no treatment and see what happens, or we would use behavioral treatment or maybe even guanfacine or clonidine, a low-grade medicine. Lumpers, on the other hand, tend to see Tourette as the overarching disorder and the singular explanation for everything. And so what they tend to do is they tend to see and focus on reducing tic severity as kind of core treatment. And this was a diagram that was not recently, but published in a very major medical journal. And you know what? This diagram is just wrong. So what it says is that in order for you to have Tourette syndrome, you have to have tics, you have to have OCD, you have to have ADHD, and you have to have behavior problems. That's why I see it points right here where all 4 of those things overlap. Well, that's not what Tourette is. Tourette is not the overlap of all of these things. Tourette is really motor and vocal tics only. So I've redrawn this for you. Tourette includes some people who just have motor and vocal tics, some people who have ADHD and tics, some people who have tics and OCD, some people who have tics and behavior problems, and sometimes they have all 4, or they have 2 or 3. But Tourette is really about motor and vocal tics only. It is not about all of these conditions. So if you think about it, this is what Tourette is, but there are people who just have tics and OCD, tics and behavior problems, tics and ADHD. It isn't everything. It is motor and vocal tics. So let's get to some med treatment. I tend to break it up into small, medium, and large. And the small treatments for Tourette symptoms, medication treatments, are clonidine and guanfacine. I think the latest data suggests that neither of these are actually that effective. But you know what? People use them a lot. Doctors use them a lot, recommend them a lot because they are relatively easy to take. The side effect burden, not terrible. My problem with them is I don't think they're usually very effective. They can be effective for the ADHD symptoms that some of these kids experience. So some kids get better with these medicines, but it's usually when they have ADHD and they're benefiting from ADHD. These medicines have been used historically. They're not at all used now, simply because they were done many, many years ago. They had benefit, but if you think about it, antidepressants reduce anxiety and depression. Benzodiazepines reduce anxiety. So, if you think about it, if you have a person who's got a tic disorder with anxiety and you give them a medicine for anxiety, it may have a nice impact on tics. These are the antipsychotic medicines that I've listed here, both with the generic name as well as the brand name. And I've kind of listed them in order of evidence and ability to reduce tic severity. And there's the old ones with Pimozide and Prolixin probably being the favorite over haloperidol, and risperidone and aripiprazole really being the medicines of choice for most docs today. In Europe, they tend to use a couple of different medicines, sulpiride and tiopride. They're not available in the United States, but and probably never will come here, but they use them there. Botulinum toxin, which is more often used for removing wrinkles and improving facial appearance, can be used to reduce big muscle tics. So people who have a very singular muscle movement that is really impairing sometimes get an injection of botulinum toxin into that muscle, which offers a mild paralysis, and so the tic actually stops for a period of time. Some people who have had severe coprolalia will get an injection of botulinum toxin into their vocal cords, and you may, if you go to a meeting in person with someone who has had botulinum toxin in their vocal cords, you will hear them with a kind of a gravelly voice, because they've had some vocal cord dysfunction due to the botulinum toxin and the treatment of vocal tics. You know, we've come a long way. You know, we do behavioral treatment now as the kind of first treatment of choice, but we're also working to try and understand whether for those people who have the most complicated syndromes, whether behavioral neurosurgery may actually be useful. And so we've done deep brain stimulation. And essentially what that is inserting probes into the brain and creating a small electrical charge in certain brain regions that actually decrease the symptoms of disease. So we use it for Parkinson's disease, for tremor, and for some severe and refractory obsessive compulsive disorder. We also use it in childhood dystonia. This is a group of neurologic conditions where kids are kind of frozen into positions because they're experiencing severe muscle contractions, and deep brain stimulation loosens them up so that they can actually walk and function. Deep brain stimulation has been used for depression, and it's also been used occasionally for Tourette syndrome. Essentially, this is what the mechanism looks like. That thing in the middle is the pacemaker of sorts. That's where the electrical charge is, and then there's the wire, and it sits in your chest. In girls or women, the stimulator sits in the abdomen. The wire runs up the back of the neck, and it's implanted into the brain region. Probably close to 200 patients have been treated now. This is an older review of the Tourette database. And what you see here is it's been used a lot. It can be useful. As side effects, believe it or not, are actually pretty uncommon, that most people tolerate this procedure pretty well. So it is something that is available for those who have the most severe Tourette syndrome. There are a variety of treatments that I say have no legs that may have at one point or another demonstrated effectiveness in a clinical study, but really now no one believes that they're useful anymore. And so I've listed them here: baclofen, ziprasidone, pergolide, and glutamate agonists and antagonists. They were hot for a while, but they're really nobody really uses them. So there are very special challenges in kind of managing kids with tic disorders. Most kids that I tend to see are prior to puberty, and so the big issues there are ADHD and anxiety disorders. But adolescents who have a tic disorder, who may have had anxiety for a long time, or are now suffering from depression, or experimenting with substance abuse, or really are feeling so uncomfortable going to school that they begin to drop out. Those kids are very challenging and require a multimodal treatment plan. Just getting rid of their tics is not going to be an effective strategy for them. They need a very complex multimodal approach to treatment that's going to kind of address all of those challenges. You know, the other thing that we're tending to see in our culture in general is young adults really having problems transitioning into adulthood. And, you know, kids with Tourette are in that same culture. And so, but they have an extra reason that may make it difficult for them to transition. So if they've had tics for a while, if they have untreated anxiety and depression, those are the kinds of things that make it difficult for them to build confidence and competence and to kind of become independent and function in the world. You know, the other thing that we tend to see is that there are sometimes kids whose parents are really struggling themselves. They may have Tourette, they may have anxiety, depression, or other kinds of difficulties. And so it's very difficult in those circumstances to help the youngster with Tourette if we can't really get the parents back to where they need to be in terms of effective leadership of the family. And then the other thing that some of you may have heard about, but is a hot topic recently, and it's called TikTok tics. So what is that all about? Well, there are an increasing number of kids who are presenting to emergency rooms or presenting for neurological evaluation who have a very atypical set of movements that sometimes get thought of as tics, but probably aren't. So as you recall, we mentioned that tics start in childhood. Males are more commonly affected than females. Tics usually start very simple and they become complex over time, and they start motor and they go to vocal. They have this sensation that occurs prior. And the impairment related to those motor movements is really not that great. The comorbid stuff is usually the bigger impairing condition for kids. With TikTok tics, it tends to be teens, 14, 15, 16 onset, tends to be all females. The symptoms are quite elaborate. There is no premonitory sensation. The kids are maximally impaired, so they get hospitalized, they stop going to school, they can't function within their peer group. The movements are the biggest problem that get in the way of social interaction, family function, education. And what's interesting is some of the kids are actually presenting with symptoms that are very similar to those kids who have done videos on TikTok of their tics or of other elaborate, extraordinary movements. The real challenge or problem is that for those diagnosticians who are not familiar with what tics really are, which is on the left side of the screen, and who get confused by the elaborate and complex nature of these movements, they begin to think about using big medicines and big treatments, including deep brain stimulation. So this is a group of patients where we don't believe that they really have tics of Tourette syndrome. They have another movement problem, shouldn't be treated as if they have a tic disorder or Tourette syndrome. And their evaluation and management needs to be very careful because we don't want to give these kids very large or extra large treatments. In general, what we tend to do with these patients is we tend to do more structure, guidance, refocusing, more rehabilitation type strategies, more behavioral strategies to get these kids back functioning again. So less is more is the treatment plan. For those of you who are interested in this phenomena, you can read about it on the net, but there's also another example where over a dozen young women developed these kinds of movements in Leroy, New York. This was a number of years ago, and the movements came out of the blue. 13 or 14 of these young women all became symptomatic at about the same time. And so you can read about that whole process of trying to figure out what the cause was and what the treatment was. For the vast majority of folks in that situation in Leroy, New York, most of those movements went away over time with conservative management. I always get a question about complementary or alternative interventions. So, what's interesting is we have nicotine. So kids with Tourette have been given nicotine patches. Adults with Tourette have been given nicotine patches, but they've also been given nicotine antagonists. So anti-nicotine medications. Both seem to have worked at one point or another, but right now nobody's investing there because naloxone and naltrexone are medicines that stop repetitive behaviors, particularly around drug use or alcohol use. People have thought, well, if there's a repetitive part of this Tourette syndrome, maybe it's a habit or a ritual. And so maybe if we use an opiate blocker like naloxone or naltrexone, that we may actually begin to reduce. Patients have reported that marijuana will decrease their tics. So you're seeing a lot of folks beginning to think about this. What's hard for us as medical professionals to understand is whether marijuana actually reduces anxiety and thereby reduces tics, whether marijuana just makes people less concerned about their tics, or whether it really does have a direct effect on tic severity. The data is just not clear, but patients definitely report that they have some benefit from marijuana. The other challenge is that smoked and vape marijuana is toxic. And what's ironic is that sometimes these patients don't want to use prescription grade pharmaceuticals, but they're willing to smoke marijuana or vape marijuana when they really don't know what's in it. And the toxicology of that is potentially high. We are seeing.
Dr. Walkup, just wanted to let you know we've got about 10 minutes before the break.
Perfect. That's great. I think we're in a pretty good place. You know, I might, let's see. Yes. So again, there'll probably be lots of questions about marijuana and CBD and other kinds of medicines like that. We've also tried hormones. You know, we've because tics more commonly occur in boys than in girls, we've given androgen blockers. You know, medicines that work against testosterone to decrease that male hormone, if you will, to see whether that has a difference, makes a difference. And it did a little bit in the beginning, but maleness tends to dominate, and so there was a increased surge of androgens in response to the blockade. Omega-3 is something that you hear people talking about more often for mood regulation properties. The benefit there is usually pretty small, but some people find that it's beneficial. Health supplements. I have no problem with health supplements. I just want to encourage people not to expect a whole lot from these kinds of interventions. That behavioral treatment is really the way to go, most effective, most potent, with best outcomes. I think, you know what, let's break now and go till 12:30. So take 10 minutes now, and we'll kick off with pandas as the next piece. In the break, we'll review the questions that came in the chat, and when we come back, we'll answer those questions and then kick off with pandas. How does that sound, guys?
Okay, I'll be emailing you, Dr. Walkup.
Okay, I'm pulling it up. Thank you all. Take a nice break. Hey guys, can we talk a little bit privately?
Yes, I'm just not sure. Hold on, I'm not sure if it's, It's not going to be privately, I don't think. So I'm trying to think of the best way to go about this. All three of us can speak.
Okay.
Unless, Barbara, if you just want to give Dr. Walkup a call, and then I'll do it for the next section.
Where are the questions? And are they in an email?
Yes, I just emailed them to you.
Okay.
Do you want to touch base on the phone?
Yeah, let me pull up my iPad. I'll look at them on my iPad.
Okay.
I'm having a snack.
If you do want to speak, we'll just have to talk to each other on the phone.
Okay. That's so interesting. We can't turn it off for others.
No, I don't believe we can. Chelsea, did you want to send me the phone number? Did you?
Well, do you want, Dr. Walkup, do you want to chat?
I'm looking at the session questions.
Okay. And I'm collecting more that we can use during the next break because there are still more coming in now.
Yeah, there's lots of them. Wow. Okay. Are you going to send a separate email with the subsequent ones?
Yes, I will. I'm still collecting them. There are quite a few.
Yeah.
You might have to do the second set after the next break.
Well, yeah, I will just say quickly for anyone who is here and can hear us, that, yeah, we do have so many questions rolling in, as I'm sure you can hear us discussing. And what we're doing is we're collecting all of the questions, questions that we aren't able to get to today. We will do our best to either work with Dr. Walkup after today's seminar to gather the answers and send follow-ups, or, you know, later on we will share with you the direct support email address and phone number that you can contact at our national office. So we'll make sure that everyone gets taken care of.
Hey, Chelsea, do you know what slide we're on in the total picture?
Pandas.
I understand that, but what number is that? Slide
Oh,
30?
I can't see what number.
Oh, okay, okay. Because that will give me an idea whether I can, because I have relatively brief answers to most of these questions, and that may require people to kind of do a follow-up question, if you will. But I can get to most of these pretty quickly.
Okay, great. So it's 12:29, so Eastern time. So we'll give one more minute, right? And then we can start answering.
I can tell by the questions. I can tell by the questions that I don't quite know exactly how to say this, but we're talking about things that are on people's minds. So I hope that's good.
It's 12:30 Eastern time now. Do we want to get started?
I'm ready.
All right, so let's get started answering
Okay.
some of these questions.
First question, is Tourette a lifelong diagnosis? Well, it is for some people, but there are people who have had tics for more than a year, had a Tourette syndrome diagnosis, but effectively by the time they're 25, 26, 27, they have no tics left. They can tell others that they've had Tourette syndrome in the past, but at that point, they don't really meet criteria for Tourette syndrome currently, if you will. So I don't think of it as a lifelong diagnosis. I think about it as a diagnosis that occurs as long as people have motor and vocal tics, and they've had them for longer than a year. You know, we often wonder about environmental conditions, foods, pesticides, all those kinds of things making tics worse. And the problem is that the ability to study those questions is really, really difficult, because you can't really expose a group of children to pesticide and not another group of children to pesticide to figure out whether it makes a difference or not. So you're left with surveys and experience and large data. And oftentimes those studies are not developed to study the impact on tics. So it's very, very difficult to answer that question. I think in general, you know, we live in a reasonably safe world. There's lots of junk out there, but the vast majority of people are pretty healthy. When I think about what really puts us at risk, I think diet, exercise, you know, the big things that we have control over, from a healthy point of view, are probably bigger than perhaps other issues. A question about phobias, insects and spiders. The one thing about a specific phobia is about 70% of kids who have a single fear will have another one of those big three diagnoses: separation anxiety, social anxiety, or generalized worry. So it's, once I hear about a kid who's got a single fear, I do a more full or complete evaluation to determine whether they have an anxiety disorder. There was a question about a 13-year-old who had a sudden onset of verbal and motor tics. And the question is about kind of how to manage. And that's, as you know, as you've seen from the charts, that's a little late age of onset. And so that's a kid where I would make sure that they see somebody pretty good from a tic evaluation point of view and get a really good diagnostic workup. The question is really about joining school and keeping her home. You know, again, you got to do what you got to do. But I think as I listen to that case of that 13-year-old, I would make sure that they get a really good diagnostic assessment. You know, there's a question about helping kids face their fears or face their challenges. And, you know, human beings get strong. Human beings are generally resilient by nature, and they get stronger when they face their challenges. I can flood and overwhelm a child by asking them to face an unprecedented challenge, if you will. But in general, a sensitive approach to helping kids grow by facing their challenges and taking on adversity is really, really important for growth and development. But it has to be staged, it has to be planned, it has to be thoughtful. It can't be throwing the kid in the pool and teaching them how to swim. But we know that kids get stronger when they face challenges, and they face challenges with adequate support and backup. Is CBIT effective for Tourettic OCD? You know, Tourettic OCD CBIT is the treatment for Tourettic OCD. So yes, absolutely. What's the difference between flashbacks and PTSD? PTSD is the syndrome post-trauma. And it includes the experience of flashbacks of the trauma. So for kids who have been traumatized by a specific event, they will have recurrent intrusive thoughts of that event again. And that is a symptom of PTSD. And they sometimes families will say that's a compulsive thought when it really isn't a compulsive thought. It's a flashback of the trauma. Where can I find good parenting skills for anger issues? You know, many people in the Tourette community love the book by Ross Green, who's going to be the keynote at the convention here, the conference here. And he talks about the explosive child. There's also another author, a guy named Stanley Turecki, Turecki, who talks about parenting strategies with kids who are explosive. Sensory problems. These sensory sensitivities are things that we do see in kids with Tourette, but we also see them in typically developing kids, anxious kids, some ADHD kids, and some kids with developmental disabilities. When I hear about kids who have sensory problems, I want to make sure that I understand the full spectrum of issues that they may have and not just think about sensory and Tourette, but I want to know what the other parts of that youngster is all about. And the strategies for reducing those sensory sensitivities is exposure. But it is tricky. With these kinds of things, you have to really be careful and work with a professional to think about how best to help kids reduce their sensitivity to loud noises or smells. The ADHD confusion graph, what I'm trying to say in that graph is that between the ages of 4 and 7, every mental health problem presents with wiggling, squiggling, and inattention. And so because we've spent so much time talking about ADHD in our culture, every kid, no matter what they've got between 4 and 7, is going to get the diagnosis of ADHD, whether they got ADHD or not. And that's why it's really important for people who have tic disorders, because tics are associated with anxiety and OCD and learning issues and a variety of other things, that they don't just settle for an ADHD diagnosis between the ages of 4 and 7, that they get a really good diagnostic assessment so they know what the problem is and so they can really hone their treatments in on what's going to work. And again, here's for comorbid OCD, is it best to treat with an OCD specialist? You know, this is the situation. If the kid has a few tics but really big OCD, I would go to an OCD specialist. I wouldn't go to a tic specialist. We tend to see, you know, people going to tic specialists when they got a bigger problem in another domain that could be handled better by somebody else. And so I really push for following the big impairing condition and getting the best treatment that you possibly can for that. Okay. There's another question about the tics are not getting better in a 20-year-old. So the 20-year-old who is having tics, couple of things. They should be getting better, right? That's what we talked about early. If they're not getting better, what I worry about is untreated anxiety, untreated depression, and whether they're facing stress. So I worked with a person a while back who was 22, who had tics as a kid, but had started having severe tics at age 22. They had tics at age 7 or 8, but they got really worse. And what was interesting is you took the history of that person, and what they did is they took on an extremely challenging job that was enormously stressful. And so under that stress, the person's baseline tics increased dramatically in the early adult years. So when I'm hearing about an atypical presentation of tic severity in a young adult, I look for untreated anxiety, untreated depression, and whether they're under inordinate amounts of stress, and that's what's driving their tic severity. Coprolalia, I really like behavioral treatments for coprolalia a lot. The habit reversal strategy for that is diaphragmatic breathing. And I think it works as well as anything. I'm not a big fan of medicine for coprolalia, believe it or not, because I think it doesn't work as well as the behavioral treatment. What kind of doc deals with behavioral treatment? Those are psychologists, folks, although we've trained nurses to do it, occupational therapists to do it. So there's a variety of professionals who can do the behavioral treatment for tics. how likely or unlikely is for onset of tics to start in late adolescence for Tourette? Usually those kids who present in late adolescence had tics when they were 7 and they were mild, and then in late adolescence they developed a depressive disorder, or their anxiety kicked up, or they are under inordinate amounts of stress, and all of a sudden their tics blossom and flourish. But I can usually trace them back to age 6, 7, 8, 9, and they're worsening in the late adolescent. That for me feels that's a typical kind of presentation, if you will. New onset in late adolescence is rare and needs a real close diagnostic workup. Have you used TMS for patients with TS? You know, that it's TMS is just beginning to, this is transgenic magnetic stimulation for TS patients. Something's going to happen there. I don't think we're quite there yet. Given that Tic OCD subtype is not responsive to OCD med, what does work for this subtype? The behavioral treatment works for the Tic OCD subtype, and tic reduction medicines work for the Tic OCD subtype. So low dose antipsychotic medicines work for tics as well as the OCD subtype, but my preferred treatment is really the behavioral treatment. Oh, this is, man, this is a great question. So a kid with Tourette and anxiety, after 18, you expect the tics to go down. What do you expect to happen to the anxiety? Well, what happens with anxiety is anxiety sometimes goes up and stays persistent into adulthood. That's why you want to recognize it early, treat it early to remission, and make sure that it isn't part of that kid's growing and developing going forward. If you put a child into remission from anxiety in childhood, the chance that they will then have a natural course of tic improvement in adolescence is much greater. So that's why I spend so much time talking about anxiety, because for the 7, 8, 9, 10-year-old, that's when tic starts, that's when anxiety starts. People oftentimes worry more about the tics than they worry about the anxiety. The anxiety has bigger consequences long term. Treat that anxiety, get that under control, see what happens to tic severity. Hopefully what happens is that the anxiety goes to 0 with good treatment. The tics will then have their natural course, which is decreasing in mid to late adolescence. Yes, is there a connection between autism and Tourette? This is a complicated question, but again, as I've mentioned, I see a lot of kids with Tourette who also have developmental disabilities like autism, ASD, of all varieties of severity. And again, these are kids that need a very careful evaluation, both from someone who knows something about Tourette and its comorbid conditions, but also someone who really understands autism. So people talk about accommodation as necessary. You know, if I'm working with a family and they take one step backwards through accommodation in order to plant their feet to begin to move forward in a positive way with their youngster, I don't have any problem with that. And sometimes you need to kind of cut a kid some slack in order to kind of get to a place where you can mobilize resources and move forward in a powerful way. But in general, accommodation essentially tells the child that he can't do it. And we don't really want to be in the position of telling any kid with Tourette that they can't live a wonderful, productive life, because we know that many adults with Tourette live wonderful, productive lives. And so we want to be building those kids' lives, not helping them pull back from life through accommodation. Who's the right doctor to diagnose anxiety? Anxiety is child psychiatrists, psychologists, probably are the best folks to do that, and we treat that with SSRI medications. Those are the the Prozacs and the Zolofts of the world, and with cognitive behavioral therapy. Interested in learning about OCD meds that don't work? Is Prozac one of them? No, Prozac works, but not for everybody. International school teacher. My son and I have lived internationally all my life. Diagnosed with anxiety. Oh man. Oh, so this is a question about, You know, if you have a kid with Tourette and anxiety, do you live a restricted lifestyle to make it easier for them to cope, or do you give them lots and lots of experiences? You know, you can flood a kid with anxiety and Tourette with lots and lots of experiences. But what I would be saying is I would treat that anxiety and get that down to zero, because we can get kids to remission. If you can get them into anxiety remission, then they're free to go. So my cases during COVID-19 of anxiety disorder, where they've been treated to remission, they look at me like, COVID, schmovid, who cares? I can deal with this because I'm in a good place. I've treated my anxiety. Yeah, you know, for anxiety disorders, you need a mental health professional. Cannabis oil, you know, people are doing it. As long as it doesn't do any harm and you don't spend too much money, the data is just not there to support it, though. You know, families always worried about what may have caused their kid to have tics, and I think the biggest issue is genetics. But genetics are complicated. The chance for some kind of life trauma or injury or other kind of thing being causal for Tourette is extremely unusual. You can't really find much in the literature to suggest that those are the kinds of things that cause Tourette. Yes, we use the stimulants for ADHD in kids, and I'm going to talk about that in a little bit. We're going to talk about behavioral treatment. Oh, and we have an adult here with Tourette who's asking a question. Yeah, pramipexole. Yeah, there's a whole variety of medicines that can be useful depending upon the right diagnosis and the medicine being targeted towards the right condition. So I'm glad you've had a good experience with treatment with your local practitioner. Okay, back to the lecture. Okay. Great set of questions, guys. Took 15 minutes. Are we back on?
Yes.
And you heard all that. I hope.
Yes. Thanks for addressing all those questions, Dr. Walkup.
Okay, this is good. Get rid of this, man. We don't want to see that. How did that get there? Come on. All right, we're talking about pandas. Pediatric autoimmune neuropsychiatric disorders associated with strep. Here's the deal: acute onset of tics or anxiety symptoms and abrupt changes in tic or anxiety severity. There has to be some evidence of a recent strep infection. It occurs really in kids under 13. If it exists, it occurs in kids under 13, and there's apparently other symptoms. The most important thing for everybody here to know is that pandas is not a validated disorder. Epidemiologic studies, the best studies we got, suggest that it's rare if it occurs at all. And you know what? We just have to be careful out there. The reason we have to be careful is because treatment has outpaced our knowledge of the disorder. And most treatments, in my opinion, should be done as part of a research study. One of the things that's happened is it used to be associated with strep, but now people are thinking about this other syndrome, which is pediatric acute neuropsychiatric symptoms. This is not necessarily strep related, streptococcal disease related, but it could be other infections, viral infections or other bacterial infections. And some of these kids are extremely severe. So they are in the hospital. They develop epilepsy. They're very, very impaired. That's not what we're talking about with kids with tics. There are some folks who think about Lyme disease, mycobacteria, other kinds of things causing this neuropsychiatric syndrome. But again, a lot of this is speculation. And the big issue with it is the treatments that are often offered for it. So this is the controversy, and these are cuts from the papers themselves. The study provides no evidence of a temporal association between strep infection and tics and OC exacerbations in kids. This is Jim Leckman from Yale Child Study Center. Overall, the available evidence does not convincingly support the concept of pandas. The diagnostic, and then on the other hand, you see people who are advocates or who believe in pandas who will say, although difficulties in documenting an association between strep infection and symptom onset exacerbation may preclude a diagnosis of pandas in some children, they do appear to meet criteria for pediatric acute onset neuropsychiatric disorders. So when they couldn't find it with strep, they began to broaden the criteria to think about other bugs. And then I think most important, and this is really the challenge for most families that get a diagnosis of pandas and head down that pandas path, is the suggestion here that while the underlying infectious and inflammatory process in PANS and pandas needs to be treated, psychiatric and behavioral symptoms need simultaneous treatment. But psychologically, if you really believe that your kid has a medical condition that's infection related, you're going to want to just focus on the infection and its related problems, and you're not going to use the conventional treatments for OCD or anxiety or tic disorders that we know actually work for those symptoms. So what we tend to see is families getting caught, if you will, focusing on the infectious and inflammatory processes and ignoring the treatments that actually can reduce symptom severity for tics, OCD, and the anxiety disorders. So I don't want to talk too much about this here. I'm assuming we will get questions in the chat, but just be careful out there. This is a complicated and controversial area. So these are the therapies. There can be false positive diagnoses, meaning that the kid looks like he's got something, somebody gives them the diagnosis and they may not. Oftentimes this is because they draw antibody levels, and antibody levels are not proof positive of pandas. But some of these kids will get antibiotics without evidence of an infection, and they'll take them for a short term, but they'll also take them for a long term. People have given kids with this steroid medicines, prednisone, that has a large medical complications associated with it. Intravenous immunoglobulin is injecting antibodies into the blood, kind of like the Pac-Man, if you will, that goes around and gobbles up all the bad stuff in the blood. Plasmapheresis is a way of filtering the blood to take all the bad stuff out of the blood, and a variety of other immunologic treatments. What you can see here is that the therapies, when I say they've outstripped the data, these are big league treatments, really big league treatments. They're expensive and they have risk associated with them. And I think it's really important for people who are heading down the path of pandas, they've gotten a diagnosis of PANS or pandas, to just be aware that some of these treatments are quite expensive, have real serious risks associated with them, and the recommendations by the people who are PANS and pandas experts suggest you should do conventional treatments too. So if you're heading down that path, just be really, really careful. Be excellent consumers. This will give you one example of the research, just to show you how complicated it is. So what they did is they compared two antibiotics to each other's over a year's period of time. And what they found is that both antibiotics worked over a year's period of time. So you could read this study and say, boy, both antibiotics work. When I read this study, there's another explanation. And that explanation is that kids got better over time, and that the penicillin and the azithromycin had nothing to do with their improvement. So this study couldn't answer the question. The only way that this study would have been able to answer the question is if it was penicillin versus azithromycin versus a placebo, so that we would have known what would have happened if the kid didn't get any antibiotic. But this is the kind of data that is used to justify antibiotic treatment for kids with PANS and PANDAS. Again, it's controversial. You need to be very careful if you're heading down that path. Be a good consumer. So what do we recommend is kind of basic? Well, if I see a kid who has an outburst, a big exacerbation of tics or OCD or anxiety, and I'll get a throat culture. And if the throat culture is positive, I'll treat the throat culture, and I might treat it for a little bit longer than usual. I won't draw titers because a single titer is usually meaningless. And when I start thinking about treatment, I would only do those treatments where I had confidence that they were evidence-based, or if I was interested in immunologic treatments, I would do those immunologic treatments within a research context so that the data that gets developed from treating a child gets put into an evidence base so that we can learn more about what works and what doesn't. So, as I said, send patients to nationally recognized centers. We don't treat elevated antibody titers. Elevated antibody titers are complicated in that there are many kids who have chronically elevated antibody titers without evidence of intercurrent infection. We don't treat exacerbations with antibiotics or immune treatments unless we have some target for treating those things. And importantly, we use conventional treatments for anxiety, OCD, tic disorders, and that's medication and cognitive behavioral therapy. Okay, CBIT. Okay, so we mentioned, remember what makes tics better and worse? Going to Disneyland and taking a test, being too tired after doing homework in the evening, asking a kid to talk about his tics or pointing to his tics and saying, why do you do that? And free to tic environments. What we want to do for kids is we want them engaged in calm, focused activities. We want them to learn how to put their mind into that zone of deep relaxation at will. And we want them to kind of think about managing their tics across all of their different environments. So here's the idea. So the first time you tic, you don't really know that you're ticking. Second time, you don't know. Third time, you don't know. Fourth time, you may say, boy, this is kind of funny. And the fifth time, you know, someone may notice and ask you, what did you just do there? What was that thing? And so what happens over time, starting at age 6 or 7, is that the young person becomes kind of aware that they have these movements, and they begin to interact with others around the movement. So parents will look at them, ask them about them, tell them to stop, all kinds of things begin to happen. And over a period of time, after having many tics, kids will begin to have a sense that a tic is coming on. That's what we call the premonitory sensation. And so the kid will feel like a tic is coming, a tic is coming, a tic is coming. And they may actually kind of, this is not conscious, but they may feel the tic coming and then they'll tic to get rid of that feeling because they know it's coming anyway, so they might as well just tic. So essentially what we do in that scenario, and that turns into a habit or a process over time, and it's totally unconscious. It's a learned kind of behavior. What we try to do with the comprehensive behavioral intervention for tic is when a kid has that sensation, we, instead of completing the tic, we want them to do an alternative motor movement that is incompatible with the tic. So I'll give you some examples in a second. The other thing that's part of this is we really want to make sure that the contextual factors that support or maintain tic expression also get addressed, and we'll talk about that with some examples in just a second. So as I mentioned, you have a tic, you increase self-consciousness, people pay attention to you, you identify your tic patterns, you begin to have the sensation prior to the tic, which starts about age 10, and then you get into this pattern of relieving the tic or relieving that premonitory sensation by ticking. The first part of it is to create awareness of this pattern within the patient, and then develop a competing response, a movement that's incompatible, and we want it to be less socially noticeable than the tic, We want them to do it for the period of time that they are experiencing that premonitory sensation. And the cool part is that because we're replacing the tic with a voluntary motor movement, we can fade or reduce that competing motor movement over time. And that's how we get rid of the tic. So I'll give you some examples while you look here at the competing responses that we have listed. So I had a young guy. I'm going to go on camera. I don't know if you guys can see me. Can you see me now?
Yes.
People can see me. Okay. So I had a 6-year-old guy who did this. He had a tongue thrust tic. His 6-year-old strategy was this. He put his fingers in his mouth to hold his tongue in. He went to school that way, and his teacher yelled at him, take your hands out of your mouth, take your hands out of your mouth, take your hands out of your mouth, take your hands out of your mouth. When I saw him, he was a nervous wreck. His family was very upset. They'd talked to the teacher. They couldn't get anywhere with the teacher because he was putting his hands in his mouth. So I said, hey, stop. Can you do this? Can you put your hand like this over your mouth and take your tongue and push it against that fat part of your finger there? And do that until the feeling goes away. So he's 6, right? So he says, I can do that. So he does this. I say, practice it for me. Push your tongue against that. See what it's like. And he says, I can do that. And I said, listen, if you don't put your fingers in your mouth, no one can yell at you. You could be like this at school all day and nobody's going to really care. You put your fingers in your mouth, everybody's going to kind of get upset. So I told the parents, I said, can you practice with him at home? And they said, I think so. Tell me how. And I said, well, when he's doing the tongue thrusting at home, all you need to do is go like this. You don't have to say anything. You just go like this, reminding him to use this competing response. That tic was gone in a week because he did something. But what was really cool was within minutes, he felt competent and confident that he could go to school and manage his tic. So that's what the competing responses do. So what you see on this slide, I'm going to go off screen, is for an arm movement, you push your hand down on your thigh or abdomen. For eye blinking, you do systemic, voluntary, soft blinking. Eye blinking is actually the toughest one, I think, to treat. Coprolalia is the easiest because what we do for vocal tics is we do diaphragmatic breathing, yoga-style breathing. If you do yoga-style breathing, that is incompatible with ticking. It's really interesting. So this is really what habit reversal is all about, is you have a tic and you do a motor movement or another activity that's incompatible. If you think about it, when people are experiencing that kind of urge to tic or in a situation where they're more likely to tic and their brain gets focused on doing the competing response, they are doing a calm, focused activity. And we know that calm, focused activities are associated with tic reduction. So there are 2 ways that this works. One is the competing response disrupts the pattern. And 2, engaging in a voluntary, calm, focused activity is also associated with reduced tic severity. So if you're a person whose vocal tics really surge in social situations because you're excited or anxious, if you're doing diaphragmatic breathing during that period of time and you're focusing on that, you will see your tics go down. There are members of the board who actually I've talked to about this, adults, who describe the capacity almost to put themselves into a little bit of a psychic zone, like self-hypnosis almost, in social situations when their tics kick up as a way of managing their tics. So we don't ever tell people that you can control them, but we do tell them that there are a variety of things that they can do to manage their tics. And so while we can't expect a kid to stop his tics, we can work with the kid and family to help the kid and raise expectation that the kid begin to take the tics on and begin to manage their tics more effectively. Okay, so here's the other part about tics. So one of the things that we see happening with kids with tics is they happen when they're fatigued, right? So they're tired at the end of the day. And when do we ask kids to do homework? We ask them to do homework at the end of the day. So a kid is sitting down for homework and he's tired and kind of exhausted and maybe a little cranky. And we ask him to do his homework, and all of a sudden his tics kick up. It's not uncommon for a parent to intuitively just say, okay, stop your homework. We're not going to do the homework now. And the reason we're going to do it is because your tics got worse. And so that's perfectly intuitive, just makes total sense. But just think about it from a behavioral point of view. At that moment, the kid's tic worsening allowed him to not have to do his homework. So in behaviorism, we call that escape. So what happened is the kid had bad tics, and as a result of having bad tics, he didn't have to do something that he was assigned. The other thing that we see is a kid has a really bad set of jag of tics, and the parent kind of feels terrible and sad and says to the kid, let me give you a back rub, or let me help you relieve some tension, or why don't we stop doing the homework and go bake some cookies? And in that context, what again, the kid experiences a bad set of tics leads to eating some cookies and not doing some homework. And so what we want to do around bad jags of tics is we want families to kind of tune up how they deal with those bad jags of tics so that they don't inadvertently reward or reinforce tic severity. One of the things that is commonly prescribed is if your kid is having bad tics at school, he should be able to get up and leave the classroom at any time. Well, if the kid really doesn't want to be in the classroom, he can have a bad jag of tics and leave the classroom. We don't really want to do that. So families will say, well, what should we do in those circumstances? Well, if they're in treatment and they're learning how to do CBIT, what we say is before homework, practice your CBIT, get your tics where you need them to be so you can sit down and really work hard on your homework. And then after you've completed your homework and have done your CBIT exercises, we're going to bake some cookies as a reward for you completing your homework. So it's a slight shift in how we work with kids and families to get them to reward taking on the challenge and participating in treatment and managing their tics rather than inadvertently rewarding kids for having bad tics. I hope that makes sense to people. So we know that for OCD and for tics, if you have that premonitory sensation or you have that obsession to wash your hands and you wash your hands or you tic, that relieves distress. So that is internal negative reinforcement. You're getting rid of a bad feeling. We know that kids who tic a lot get a lot of attention and support because they tic, so that is positive, external or interpersonal reinforcing. And when parents say you don't have to do your homework because you're ticking too much, that is external avoidance support, right? So what do we want to do from a treatment point of view? We want kids to take on the challenge of managing their tics, to learn about CBIT and about competing response and relaxation and managing all that. We want parents to refocus on engaging their child in treatment and rewarding them for engaging in treatment. And we want parents to kind of take a step back and help their child re-engage in the world and not leave the world because they have bad tics or bad anxiety or bad OCD. So it's a slightly different focus, but these are the kind of core components of that CBIT treatment. So this is the study. One of the biggest studies ever in kids with tic disorders, 246 folks ages from 7 to 65. It was 10 weeks long and with some booster sessions. And this was patient number 1 before treatment and after treatment. He had a terrific response to CBIT. So this is what we see in kids. 52% of the kids had a very good benefit versus 18 with the control treatment. Among adults, it was 38% versus 6. So there's still a lot of people who don't benefit from this. But, you know, this is a treatment that people have to work at. It's a skill. You have to practice. And so if you work at it, you can get there. But you have to work at it. So what does this all mean? Well, you know, I've changed my advice completely as a result of this. So in the bad old days, I used to say, parents, just ignore those tics. Now what I say is, no. Become aware of what makes them better, what makes them worse, what you can do to manage them, what you're effective at. Just learn everything you possibly can about your tics so that you can outsmart them. We used to say, you know, you can't control them, so don't try. Now we say, please learn to manage them, because adults with Tourette have learned to manage, and you can learn to manage too. We still say don't punish kids for ticking, but we really want to reward kids for successfully managing their tics, for taking it on and doing what they need to do. We used to say behavioral treatments won't work, so why bother? Now we say, please, please, please use behavioral strategies. We used to say don't try to suppress, you know, your brain will explode. Now we say, well, you know, as a matter of fact, if you do these behavioral treatments, your brain won't explode. As a matter of fact, that premonitory sensation might get a little bit better in that whole process, and you'll feel a whole lot more in control and powerful. We used to say suppression worsens tics. Now we know that that doesn't really happen. It worsens the urge. It may initially, but over time, with good work, the premonitory urge would begin to fade away. And then we used to say, like, well, you know, if you have one tic and you work on that, then another tic will pop up later, kind of the whack-a-mole idea. But we actually have some studies that have looked at that, and new tics don't develop when you use behavioral strategies. So we have a whole new way of talking to people about their tics and the kinds of things that we want to do to help kids do better overall. So what does this mean? Well, we still want parents to advocate on behalf of their kids, but maybe in a different way. We used to say provide a lot of support and provide comfort to your child because he's really suffering. But you know what? We really want your kid to take on the challenge of this and learn how to manage it. And we want you to be very careful how you comfort, because we want you to not reward kids for having bad tics. We want you to engage them in treatment and provide comfort and support when they behave heroically and take on the challenge. We used to say, please protect your child from all the bad stuff, and we still say that. But you know what? We want your kid to get stronger. We want their tics to be stress-proof. So you know what? Part of it is learning the skills, but part of it is also being out there in the world and learning how to manage your tics in real-world circumstances. We used to tell people, don't think about your tics, just take it out of your mind. What we're saying now, we're saying really be mindful of your tics. What makes them better? What makes them worse? How you can live with them, you know, how you're going to manage them, how other people think about you, what you can do in your world to kind of take it on. We used to say, you know, try and get the tics out. Go sit in the hall somewhere in school and tick away until all the tics are gone. We've actually learned that that actually makes tics worse. And so what we say now is, please, you know, if looks like you're heading into a time where your tics may be bad, take a brief moment to manage those tics, get yourself into a much better place, and then rejoin life. We used to say ignore the tics, and what we say now is please understand what causes them, what consequences there are, kind of how they engage, you and your tics engage the world, and how the world treats you with your tics. We used to say reduce the stress. What I'm saying is, man, I want you to have tics that you can manage in unbelievably stressful circumstances, because I want you to be tough and strong. And we used to say celebrate your specialness. And I still say let's celebrate your specialness, but let's celebrate your successes in managing your tics and living with this difficult condition and living with it well. So what does that mean? Well, you know, part of what we see is getting people ready to do all this stuff. And part of that is treating those comorbid conditions like ADHD and anxiety, and then talking with the family and the child about developing a CBIT lifestyle, which we talk a little bit at the end. I'm not going to go into that today, but it really is about being powerful and positive, talking about managing tics, not about controlling them or stopping, but learning how to manage them, using the CBIT strategies to do all that. And what's interesting is CBIT can be done alone. It can be mixed with meds. We've actually had kids on meds. We've done CBIT with them, and they've been able to come off meds. We've trained nurses in neurology clinics. We've trained occupational therapists. We have now a gazillion psychologists who know how to do this. And we're doing a lot of work with parents for kids under 9 years of age to kind of help parents learn how to do this with their kids too. So what's this all going to look like in the future? So if you haven't gotten it now, tics are important, but all they are is a marker for other problems. So when I hear about a kid who's got a tic, I assess the tic, I figure that out. But what I really want to know is, do they have ADHD, learning problems, anxiety, OCD, depression? Do they have behavioral challenges? How are the parents working and parenting them? What's all going on in the life of this youngster? And then I set up my treatment to go after those things that are really causing trouble, to reduce all of that so that the kids can function at their best. And most often, I spend most time treating comorbidity with medication and behavioral treatments, and not focused on tics other than to do the CBIT strategies. So, you know, if we're really successful at the Tourette Association, the first doctor that you run into will understand this new advice and not give you 20-year-old advice. And the first intervention that you would get would be to work with you to provide a non-reinforcing environment for tics, where you would begin to reward your child for taking on the challenge, for finding a way to manage their tics, for engaging in the world, and engaging in treatment. And that parents who got really good at all this, what they would do is they would take what they know about what works for their kids, and they would go to the school and they would educate the kid's teacher, the counselors there, and so that the school would have a parent ally who they can work with to help the kid at school. That the professionals, all types of professionals, neurologists, psychiatrists, psychologists, occupational therapists, physical therapists, nurses, that they would all understand how to go after a specific tic. That kid who had the tongue thrusting tic, he didn't get 10 sessions of therapy from me. He had about 10 minutes of treatment from me around a specific tic. And in the future, what I'd like to be able to see as a neurologist or a psychiatrist or a nurse or a social worker be able to look at a kid who's got a specific tic that's bothersome and teach that kid how to manage that single tic. And over the course of treatment with that young person, begin to work away at the variety of tics. And in the end, what you would see is kids would develop all of these strategies that they would learn to manage their tics as they go. In the long-term follow-up of kids who participated in the CBIT study, one of the common experiences that we heard is the kids said, I worked really hard initially to learn how to manage my tics, and I got my tics under control, but over time I had to think less about managing them, and they just didn't come back. And I actually think that I've figured it out, a way of less consciously being able to manage my tics without actually thinking about it. So that in difficult circumstances, I had a variety of techniques and strategies I kind of did intuitively to manage my tics. And actually, I've found that that works pretty well with me. So I can live my life, but I can also manage my tics simultaneously. So what else are we doing? Parent behavior management training. You know, we really want to make sure that parents are doing what they need to do to raise strong and healthy kids from a parenting point of view. There was a question about aggression, and Ross Green, who's going to be the keynote for this conference, is going to talk about managing kids who are explosive. You know, thinking about kind of how we take CBIT and parent competence and confidence about managing their kids. How do we take that to the schools so the schools can benefit it? But also for those adults who have had tics and OCD and anxiety and depression, you know, how do we help them kind of get back on track so that they can function in the world again and be employed form relationships and have kids and live successful lives. Shifting a little bit just to talk about OCD. You know, the mainstay of treatment for OCD is cognitive behavioral therapy, and what I've listed here are the serotonin medicines. All of these medicines are likely to work. There's evidence for some, but not evidence for all. And for those kids who are, or those adults who are really complicated, there we even have brain kind of strategies like deep brain stimulation or behavioral neurosurgery. Treatment of ADHD and tics, this is a hot topic. The biggest issue there is there's a concern that stimulants like Ritalin or Dexedrine or Adderall, they actually cause tics or permanently increase tic severity. What we've learned is that that really doesn't happen. That's not the truth. What we do know, though, is that some people will start having tics when they take these medicines, and that there's a natural course to the development of tics, and it can appear as if the stimulant treatment has caused tics de novo. And I'll give you some data here to go with this. So in 2002, it's an old study, but it's still it's an oldie but a goodie. This study compared clonidine, methylphenidate or Ritalin to the combination of the two versus a placebo for ADHD in kids who had tics. The bottom line was they all worked. So clonidine worked for impulsivity and hyperactivity, and methylphenidate worked for inattention, or Ritalin worked for inattention. But they also kept track of tics as a side effect. 20% of kids on Ritalin, 26% of kids on clonidine, and 22% of kids on placebo all had tics worsening. If you look at this data, what this means is that it's not the drug, because placebo causes more worsening than methylphenidate. And clonidine, which we know is we use to treat tics, actually had the same amount of worsening, if you will, as methylphenidate. So essentially what we see here is that over the course of a treatment study, kids have between a 20 and 25% chance of tic worsening no matter what you do to them. So when you read about a medicine or an environment or something making tics worse, you have to think that between 20 and 25% of kids are going to have tics worsening from some moment or encounter and looking forward. So it's really important to not get locked into the idea that the med caused it, when between 20 and 25% of kids, once they start a new med or start a new intervention, are going to get worse in terms of their tic severity. So another study looking at just kids with ADHD who don't have tics, right? This is a large group of studies where kids were just treated with ADHD. What happened there is about 5.7% of kids on stimulants developed tics, brand new tics, and 6.5% of kids on placebo developed new tics. So when I'm working with some kid who's just got ADHD, no tics, and I start them on a stimulant, I share with them these numbers. I say, listen, your kid has about a 6% chance of having tics start over the next, weeks to months after starting a stimulant. And it's not because the medicine causes it, it's because tics are around and start about the same time that we begin to treat kids for ADHD. Remember, ADHD starts between 4 and 7. We start treating kids between 6 and 12. That's when anxiety starts, but that's also when the tic disorders start. So it is a coincidence that the start of a medicine treatment is associated with changes in tic severity or a new onset tic. That said, I do this kind of an informed consent process, and it is really important for parents to understand this point down here. And that is, if I give your kid a medicine and he starts to tic, I will take that medicine away, but there is no guarantee that that tic will go away, because if the kid was destined by nature or by God to have a tic disorder, it won't necessarily go away when I get rid of the medicine, because he may have developed the tic anyway. So there was a study of identical twins. Remember, identical twins usually both have tics. But the study looked at a small group of twin pairs where one got a stimulant and the other didn't. And what was interesting about that study was that the kid who got the stimulant had tics start a few months before the co-twin who didn't get the stimulant. Now that's a little interesting. Like, why would you give one twin a stimulant and you wouldn't give another twin a stimulant? Separate topic. But yes, the stimulants may cause something to happen, but they're not going to cause tics. But if the kid takes the medicine and he starts to tic, most parents are going to make that connection in their own mind. And so that's why it's really important that you understand this slide really closely if you're starting to think about treating your kids' ADHD with stimulants. Okay. These medicines, clonidine and guanfacine, these are commonly used for ADHD. They're commonly used for tics, but I think their real value is more about ADHD. Again, here, this is the data that shows that this stuff works. Probably doesn't work as well as the stimulants, but people like using guanfacine for ADHD and tics because then they don't have to quite deal with the stimulant idea and stimulant worsening of tics. Atomoxetine, you know, there are people who really believe in this one and like using this one. It's probably not as potent or as effective as the other alternatives, but you know, it's not a bad thing to try. Just don't get your expectations up too high. These are the big anxiety disorders: separation, generalized, and social, and I've talked a little bit about them. We have terrific treatments for them, both medication as well as psychotherapy. This was the big granddaddy or grandmother of them all studies that proved that our medicines work and CBT work. These are really interesting data, so I'm going to spend a little bit of time here. So the response rate, this is better, much better. 80% of kids who got med and CBT got better. If they got CBT only, 59% got better. If they got medication only, 56% got better. And if they got placebo, oop, that's a typo, that should be 24%, got better. What this means to me, the low placebo response rate means that you have to really help these kids with treatments that work, like meds or CBT, in order to get them better. Remission, which means no symptoms, gone. The combination treatment, 65% of kids went into full remission at 12 weeks. 35% if they just got CBT. 46% if they just got medicine. At 24 weeks, when the kids reached maximum benefit, they flattened out at that point. It was 65%, 45% for CBT, and 48% for medicine only. Most families don't want to use medicine. But when you look at remission rates, there's a 30% difference between using medicine and therapy and using therapy alone. So when families choose to do therapy and reject medicine, they are choosing to use a less effective treatment for anxiety than they could be using if they use the combination of medicine and psychotherapy. Why is that important? Long-term outcomes for kids with anxiety, the best outcomes occur for those kids who had early remission. So if they took a longer time to get to remission or they never got to remission, those kids didn't do very well long-term. So what I try to do with families is I want to say, listen, let me get your kid to the very best place I can get him as fast as I can at 12 weeks and get him into remission by using everything I've got, which means medicine and psychotherapy. The other thing that's really interesting is that those kids who didn't get better with CBT, so remember about 35% at 12 weeks remitted, that means 89 kids didn't remit. They weren't better. After 12 weeks, those 89 kids could add medicine. but only 26 kids added medicine at that point. 63 kids, even though they weren't in remission, didn't do the next step in care, which was to add medicine. So something happened in clinical care out in the community. What happens is therapists start with kids, and if they get them to remission, that's great. If they don't get them to remission, they just keep going. And oftentimes, they may themselves have a bias against medicine. Families don't want to add medicine. They've worked pretty hard in therapy and they're just kind of tired of working and they don't want to do something new. And so what happens is kids don't get the best outcome because they don't do stepped care. They don't start with CBT and go into remission. They start with CBT, and if they're not in remission, they don't add medication. And so one of the things that I'm now saying to my families is please, please, please do what you can. Hard, fast, early in treatment. Take advantage of the fact that early treatment with combination of medicine and psychotherapy gives you the best chance for remission, and the best chance, and early remission offers your kid the best long-term outcome. Okay, going to talk a little bit about behavior problems. How are we doing here for time?
Well, we have about 20 minutes.
20 minutes, okay.
Actually, no, I'm sorry. We have about almost half an hour before the next break. The next break is at 2.
Okay, all right, so I'll keep going here. We're going to talk about behavior problems. So are you ready? There are 2 ways that children develop behavior problems. One, they engage in a lot of power struggles with their parents, and their parents aren't paying a lot of attention to what they're doing. So why are power struggles such a big deal? Well, they're based on this idea of negative reinforcement. Oh my God, what the heck does that mean? And the strategies, once you get into a power struggle with your kid, they just escalate and escalate and escalate, right? It just gets worse and worse and worse. And so it gets more and more troublesome over time. And then poor supervision is the other thing. That's knowing where the kid is, what they're doing, who they're with, paying attention to kind of what's going on. Supervision is really part of early infant care. It's about safety and nurturing. But in adolescence, it really is good supervision is the behavioral treatment of choice. So I'm going to go back and talk a little bit more about power struggles. And I'll give you the example of a guy named Billy, whose parent one day said, Billy, you're 7 and it's time for you to make your bed. So Billy, make your bed. And Billy says, no, I don't want to. And the parent says, come on, Billy, you're old enough now. You can make the bed, make the bed. And Billy says, no. And the parent says, oh, okay. I'm not going to fight with you today. You have to go to school and I got to go to work. At that moment, Billy was just trained to say no twice. People understand that? When the parent capitulated to Billy's no, that parent just trained Billy to say no. So the next day, the parent says, come on, Billy, make your bed. He says no. Come on, Billy, make your bed. He says no. The parent says, I've had enough of this no business, Billy. It's time for you to make your bed. Make your bed or else. And so Billy says, all right, chill. I'll go make the bed. So he goes and makes the bed. At that moment, the parent was just trained to demand twice and then threaten. Billy hated that moment. So the next day, parent says, make your bed. No. Make your bed. No. Make your bed or else. Billy says, make me. And the parent goes like, what? What do you mean make you? Make the bed or else. And Billy says, no way, I'm not going to do it. Forget it. The parent says, oh, this is ridiculous. Go to school. I'm going to work. At that moment, Billy was just trained to say no twice and to challenge the threat. So he thought that the parent was bluffing. He called the parent's bluff. And so now he has an additional strategy to defeat the parent's expectation. The next day, the parent says, okay, Billy, enough of this. Make your bed. No. Make your bed. No. Make your bed or else. Make me. Come on, Billy, you have to make your bed. You've got to do it. Okay, you're grounded. I'm taking away your Nintendo. I'm taking away your Xbox. We're doing whatever. And Billy goes, oh my God, okay, I'll go make the bed. I didn't realize you were that serious. So now what you've got is you've got a parent who just got trained to demand twice, to threaten, and then now engages in punishments in order to get a kid just to make the bed. So the next day, Billy hates this. He's getting so much resentment and so much anger. The next day, make the bed, no, makes the bed, no, make the bed or else, make me, make the bed or else, I'm taking away or whatever. So what Billy do? He runs into the bathroom and he locks the door. And so the parent goes to the bathroom door and pounds on it and says, Billy, come out, Billy, come out. And if Billy's really smart, Billy doesn't say anything in the bathroom. He just is very quiet in there. And the parent starts getting worried that he's in the bathroom and there's all kinds of stuff in the bathroom that, you know, maybe he's not safe. And the parent starts getting worried and Billy's not talking to the parent anymore. And so the parent says, okay, Billy, you don't have to make the bed. Just come out and go to school. So Billy unlocks the door, comes out, he goes to school. But look at what Billy just learned how to do. He learned how to argue, talk back, call the parent's bluff, and then run away. So what does the parent do the next day? The parent next day stands in front of the bathroom door to prevent Billy from running to the bathroom door. So now you've got a parent who's demanding, threatening, punishing, and using physical strategies to manage their kid's behavior. This is that escalation that all comes from power struggles. So many of the behavior problems that kids with Tourette develop over time develop in the context of this negative reinforcement paradigm of power struggles. So parents will say to me, my child doesn't listen. And I say, well, why do you think that is? And they say, well, I don't know. I wouldn't be here if I knew why he didn't listen. And I say, well, my guess is that the reason your child doesn't listen is because you talk too much. And they look at me kind of insulted. And I said, the more you talk at your kid and explain and lecture and do all that kind of stuff, the more their ears turn off and they stop listening. And they do things like, huh, what, huh? And, you know, you get so frustrated with them when it seems like they're not paying attention, they're not listening to you, you give up. So they're not listening is a very effective strategy to get you to be quiet and to go away. Parents will say to me, well, you know, my kid tells lies. Why does my kid lie to me? And I said, well, the reason your kid lies to you is because you probably ask questions. And they go like, what? I said, well, do you ever ask him if he did his homework? Yeah, I ask him all the time. I said, well, what does he say? He says he did and he didn't. And I said, well, you probably should know whether he did his homework or not and not ask him. If you're depending upon getting the answer from him about whether he did his homework or not, you're one click behind. So, well, how should I know whether he did his homework? Well, you know, you kind of got to pay attention. You got to know what the expectation is. You got to know what he's doing in school. You got to know the teacher. You kind of got to be on top of this stuff so that you don't have to ask the questions, so you don't have to teach him how to lie by asking questions. Billy, did you eat the cookies? No, I didn't eat the cookies, Mom. My brother Jimmy ate the cookies. So this is the kind of thing that now transforms into a family problem in general, because Billy actually ate the cookies. He blamed his brother Jimmy. Jimmy gets mad at Billy. Billy and Jimmy get into a fight. The parent throws up their hands, gets upset, and you know what? No family really understands how power struggles train children to misbehave and actually force parents to use parenting strategies that they don't like using. And it all comes out of this power struggle business. So when I'm working with a young family, the thing I want to do the first and most importantly is develop parenting strategies that really end the power struggle. The other thing I want is I really want them to pay attention and supervise. So if you think about it, you know, a mother of an infant or a father of an infant, what's really important for them to do is they learn what the what the wet cry is, what the hungry cry is, and what the tired cry is. And you can imagine if the parent is really good and they understand the hunger cry and they feed the baby, and the tired cry, they put them down for a nap, and if they're wet, they change their diaper and make them comfortable again. If the parent really gets all that, that kid is going to be really happy and really attached because the parent was paying attention, knowing what the kid's needs were, and meeting those needs. But we see many parents who don't really always understand what their kids are trying to communicate to them. And so I talk with families sometimes about whether their kid is transparent to them or whether their kid is opaque. And so if a kid is transparent, the parent will say, I know my kid inside out. I know what he's thinking. I know what he's feeling. I know it before he knows what he's thinking and feeling. On the other hand, for kids who are in trouble, the parents will often say, I don't know who my kid is. I don't know what he's about. I don't know what he's thinking. I don't know what he's feeling. He's confusing to me. I just don't get what's going on with him at all. And if you think about it, how do we learn who we are as human beings? We learn about who we are because the people who love us know us. So my mom told me who I was. She trained me what kind of person she knew me to be, and she educated me on an ongoing basis. But many parents nowadays are confused about who their kids are, don't know who their kids are, and as a result of that, those kids grow up with some confusion about who they are and what they're about. So supervision is key to good attachment behavior. It's key to identity development. And interestingly, supervision is also key to conscience development. So my mother, she was pretty good. She's been dead for over 20 years now. But when I go into a store and I pick up something beautiful made out of glass or that's fragile or something like that, I hear her say to me, Johnny, put that down. And so she still sits inside of me. She is my conscience. She taught me how to respect other people, how to live in this world. She taught me about truth and right and wrong. And she did that by paying attention to me, identifying those challenges in my life, and providing the kind of guidance that I needed along the way. And all of that came from the fact that she was there, she was paying attention, she was watching who I was, helping me understand myself, helping me build a positive identity, and helping keeping me out of trouble. So those two things, ending power struggles and training parents how to supervise, are really the core parenting skills that every parent needs to know and understand. If it doesn't happen, if there's poor parental monitoring and discipline, kids will develop behavior problems. So Billy, when he goes to school and the teacher says, okay, everybody sit down, what's Billy going to do? Billy's not going to sit down. So the teacher goes, oh my goodness, I got Billy and he's not sitting down. What am I going to do? Well, I know what most teachers do is they forget about Billy learning and they just try and keep him in control of his behavior, and they don't care whether he learns anything. And so Billy falls behind academically. The other thing that happens is if he's oppositional enough in the classroom, he starts getting rejected by normal peers. So the families will come to me and they will say, well, my kid's having problems at school. Should I get him a tutor? And I say, well, I'm going to train you how to do effective parenting to reduce the behavior problems so that he can be educated by his teacher. They also say to me, well, he doesn't have many friends. He can't make friends or keep friends. And I say, well, that's probably because he's got these behavioral challenges. So I'm going to do parent training, reduce those behavior problems so that he'll be a fun kid to hang out with and won't be rejected by kind of typically developing or normally developing peers. So parent training in this kind of lifelong process is the antidote to many of the struggles that kids have across development. If these parenting deficits really continue into adolescence, there's the outcome there is negative peer group formation, which is like gangs and illegal stuff. But more commonly, it's the alienated and disaffected teenager who's into drugs, who doesn't respect adults, who doesn't believe in adult authority or adult institutions or the world in which we live in. They're cranky, irritable, difficult, vulnerable to substance use. Many of these kids get involved in suicidal behavior because they're kind of disconnected from that family unit in a powerful way. And for both of these groups, I go back here and I do parent training to reduce the kind of behavioral challenges and address these issues in adolescence. So why do I do parenting? Well, you know, if you look at the literature about kind of problematic outcomes in kids, you know, you hear about, you know, undereducated parents or single parents or poor parents or families that live with a lot of stress or parents who are depressed or have problems with alcohol use, or, you know, parents who come from communities where there isn't a strong strong history of positive parenting. But you know what? These are all these parent factors here on the left. All of those get mitigated by what parents actually do, because I've met many great single parents. I've met many great parents who have who've lived with great distress. I've worked with many depressed and substance abusing parents to parent more effectively and have better outcomes for their kids. And I've worked with Native American communities where there's a very a bankrupt history, if you will, due to racism, of positive parenting strategies. Boarding schools and things like that essentially destroyed the family unit in Native communities. But you can train people to parent more effectively and improve kids' outcomes. So it is the reason why I focus on parenting so much with kids with Tourette, because there's a lot of issues over here, but I'm really trying to prevent these long-term negative outcomes in kids by focusing on parenting. Kids with Tourette, that's a child factor, are much more difficult to parent. You're going to have more power struggles with kids with Tourette. Kids with Tourette are more confusing to their parents, which means they are more opaque, right? And so the combination of a parent who gets into power struggles with a kid with Tourette, or who can't really understand their kid and put it all together for their kid, that youngster with Tourette is at greater risk for the development of behavior problems, because they're just more difficult to parent. So when I'm talking with parents of kids with Tourette syndrome, I say, you know what, you need industrial strength parenting skills. Ordinary parenting skills may work for your other kids, but for your kid with Tourette, you need to be really sharp and understand what the key components of parenting really are, so that you can be effective with your child.
Excuse me, Dr. Walkup, we have about 10 minutes before the next break.
You know what? I'm gonna do this book thing, and then we'll take the break right after this. How's that?
That's fine, and I will email you the next set of questions.
Okay, so here's some books about parenting. So Ross Greene's The Keynote. I think that's right, Chelsea. Isn't he keynoting?
Yes, he is. Yep. I can actually, before the next break, I can look to see the time of the session, and we can let everyone know after the break.
Yeah, people, you know, I like Ross Greene a lot. I like Ross Greene a lot, but and he talks about how to manage the kids who are explosive and difficult. He doesn't explain why kids are explosive and difficult. He just kind of says they are. And I just explained why kids and how kids become difficult over time. Kids with Tourette are more difficult. Yes, they have a brain thing. There's no question about that. But they get into more power struggles with their parents, and they're harder to understand, and they confuse parents. And so parents really don't take advantage of all of their knowledge of their child to kind of begin to plan and manage. And what Ross does is he trains parents how to focus in the here and now and move forward. Another good book is The Out of Sync Child. Probably the grandmother of them all is Parenting the Strong-Willed Child by Rex Forehand. 1, 2, 3 Magic is one that people like. Taking Charge of ADHD by Russ Barkley. A variety of other books along the way that I think are important for families to kind of get up to speed when they're newly diagnosed. There's also some websites for therapists. This is the Association of Behavioral and Cognitive Therapy. The people who belong to this organization are True Blue and good parent trainers. And if you don't find a child practitioner in your community, ask one of the adult practitioners if they know a child practitioner, because there may be some people in the community that aren't a member of this organization, but do work with kids. And then there's the Academy of Cognitive Therapy.org. That's another group of diehard behavioral people who can really help with training parents and working with kids. So I'm going to summarize a little bit there. We just did what's in a name, Tourette, Guy de la Tourette syndrome, Tourette's syndrome, Tourette's disorder. We talked about what the various diagnoses are, the history, how we've come from it being a psychological condition to being a neurologic condition that's genetic, that is heavily influenced by the environment, where behavioral treatments are probably the treatment of choice. We know about how frequent it is. We know it runs in families and has a genetic component to it, but the genetics are complicated because it's the genetics of those comorbid conditions which are also important. We've talked about how kids get better in the mid to late teenage years unless there's comorbidity that kind of stands in their way. And we've heard a lot about the various treatments, the medication treatments, as well as the behavioral treatments. I think we are going to actually have time for me to do the extra material. So I think I'm going to leave this slide up, send you all on your break. And then for the last hour, we're either going to answer questions or we're going to do the additional material in the slide set.
Great. And before we break, I just wanted to tell everyone one thing. The website that Dr. Walkup has there on that slide, it's been updated. So it's tourette.org now, TOURETTE.org. And then the only other thing is, before everyone breaks, in case you wanted to look to register, the keynote session with Dr. Ross Green is tomorrow at 11 a.m. So you could go to our website, touretteconference.org, to register for that. And he has another session as well after his keynote session that's also tomorrow at 12 p.m. So feel free to check that out and register for those. Dr. Walkup, do you want everyone to reconvene at 2 or do you want to give them longer until 2:15? What do you think?
10 minutes is good. 10 minutes is good. Then
we'll see you back here at 2-ish or 2:01 Eastern time.
2:01 Eastern sounds good.
Okay, great.
Okay,
Hey,
just
thanks.
look for that email coming to you right now, Dr. Walkup.
Great. I'm going off mic. Hey, Barbara, it's John Walkup. I haven't seen the questions yet.
I sent the email to you. That's strange. I'll resend it.
Please do.
Okay, I'm sending it right now.
Last one I got is at 9:36.
Yeah, this
With
is
it.
at 1:52. I'm going to send it to you right now. I'll resend it.
Okay.
Did you get this set?
No, I'm wondering if there's something the matter here.
Oh, there are quite a few questions too.
Yeah.
The only
Keep that.
other, would you want me to read some of them out? Would you, since you haven't received it?
What I do is I edit some of them along the way so we don't get into a lot of detail.
I get it.
let me see if it went to my other computer.
Okay.
There they are.
Great.
Yeah. Okay, let's see. They just showed up. So let's see if they show. Oh, there it is. Yep, just showed up. Uh, you know, if people are listening, I've been in the business a long time, and many of these questions I have heard before. You know what I think I'm going to do is I'm going to answer all these questions. And Barbara, you're probably going to get some more as I keep going. Oh my gosh, it really keeps going.
So Dr. Walkup, it's now 2:03. Did you want to start with the questions?
I'm ready to go. You know, we may not do additional content here because we got a lot of questions. And there may be more as I give answers. People, they may actually have more questions. So there have been a couple of questions about teenage onset, abrupt teenage onset in girls. And when I talk about a complex evaluation for that abrupt teenage onset in girls, particularly if those kids are spending a lot of time on the internet, I worry a little bit about TikTok tics. So this is when I say you got to get a really good evaluation, you got to meet someone who really knows the tic disorders well and can help you understand whether these are movements that were there in childhood and are just getting worse in adolescence, or whether they're new onset movements. And if they're new onset movements, how they're like tics or not like tics, and kind of get a really good diagnostic assessment. The challenge during the pandemic is access to any doctor. So everybody's swamped because this is, well, there's the COVID-19 pandemic, there's the mental health, behavioral health pandemic. And so it's tough, but for all of those folks who are talking about their teen daughters with abrupt onset, really important to know whether they had tics earlier and this is just a worsening due to something like anxiety or depression, or whether this is a brand new onset of serious tics. There's a question about kind of contribution to tic severity. So just think about it. If you have anxiety and you're nervous and tense and kind of quasi upset all the time, that's going to drive tic severity. We know that kids who are calm and focused, they're going to have less tic severity. So if you have ADHD and it's not in good control and you're unable to focus or stay calm, it's going to be very difficult. Your tics are going to get worse. So the way I think about it is those comorbid conditions feed into tic severity. And the problem is that many clinicians will just look at tic severity and try and dampen the tics, as opposed to look at what's causing the tics to worsen, like ADHD or OCD or anxiety, and treat those things that worsen tic severity. So yes, ADHD and anxiety contribute to tic severity. And of course, if you have tics, it's going to be hard to pay attention. And if you have tics, you're going to be self-conscious. But the big drivers of anxiety drive tic severity, ADHD and off-task behavior, the inability to stay calm and focused drives tic severity. Question about paranoia in an 8-year-old. You know, 8-year-olds don't get paranoid, but I understand that word. Anxious kids are hypervigilant, which means they're always paying attention to lots of little details, and particularly things that they might see as threatening. So what I might think about for a prepubertal child where you're thinking that he looks paranoid, I would begin to wonder whether they have anxiety and they're hypervigilant and they're kind of tuning into stuff and appreciating new and different experiences as potentially threatening. The treatment for anxiety disorders, by the way, are the SSRI medicines like Prozac, Zoloft, Lexapro, Celexa. Those are the big ones. There is a question about chronic cough, and if you look on the internet for chronic cough, you'll see literature about chronic cough. They don't talk in that literature. They don't talk about Tourette as a cause or a tic disorder as a cause of chronic cough. And we certainly at Lurie Children's have a chronic cough clinic. It's run in pulmonology, and but I'm highly suspicious of kids with a chronic cough as a tic. And the thing about tics is that kids with tic disorders have what I call a thin stimulus barrier. And what I mean by that is if you have like postnasal drip from a cold and you sniff, what happens if you have a tic disorder, you sniff once or twice because you have a cold, but then you sniff 20, 30, 40 times because you have a tic disorder. If I ask a kid, you know, if he has a sniffing tic and I give an example of a sniff, it's not uncommon for that kid to start sniffing because I've kind of triggered that by asking the question. So that thin stimulus barrier, it's the reason why kids don't wear turtlenecks, because if they wear turtlenecks, there's that tightness around their neck, which makes their neck move. So there's all of those kinds of things that kind of drive symptoms, and chronic cough is one of those. If he has something in the back of his throat that's uncomfortable for him, or he has an allergy, the allergy is not causing the tic. The allergy is causing some dysfunction or discomfort in the back of the throat, which leads to a cough, which in a person with a tic disorder can lead to a chronic cough or a chronic throat clear. So that's kind of how I think about that. So treating the allergy to kind of make the back of the throat feel better may be a great way to get rid of the tic, but it's not the cause of the tic in that way. It's two problems, actually. Sleep disruption. You know, there are two main causes of why kids can't fall asleep. One is bad sleep hygiene. And what I mean by that is kids who don't have a predictable bedtime day in and day out and have a too complicated ritual of falling asleep. So a lot of kids read, get a story, get a back rub, have a discussion, talk about the day. All of those kinds of things contribute to difficulties falling asleep. If you want to have, you know, a bedtime experience with your child, have it in the living room. But once they get upstairs, they're laying in bed and you tuck them in and kiss them on the forehead. The lights are out and you're out of that bedroom. That's good sleep hygiene. The other thing is that anxiety disorders, kids with anxiety worry before they fall asleep. They're thinking about what happened during the day. They think about tomorrow, and they can't put their mind at rest. And so it makes it difficult for them to fall asleep. So kids who have physical symptoms like belly aches and can't fall asleep and are 8 or 9 years of age, I think about anxiety disorders as first there. Again, you know, a lot of people with tic disorders go to neurologists, and neurologists are experts at the movement problem. But if you're really worried about anxiety and OCD and tic disorders, you'll find some neurologists who are really good at that, but you're going to have more success with psychiatrists and psychologists. That said, not every psychiatrist is great. Not every psychologist is great. So you kind of got to find people who are pretty good. But if you're really thinking about the psychiatric comorbidities, I love my neurologist friends, but most of them don't do that for a living. It really is in the behavioral health, mental health domain. Picky eating could be just picky eating, but sometimes kids with anxiety disorders, because they worry about swallowing, choking, and gagging, you know, some kids with anxiety can't swallow pills. So when I hear about a kid who's a picky eater, I'm also going to ask you about whether he has trouble falling asleep, whether he has stomach aches, whether he's a worrier, because that would be a group of symptoms that all come together as part of anxiety. You know, once a kid is better on a medicine, you know, you can think about whether they got better on their own naturally or they got better because of the medicine. Most of us know whether it was the medicine that got them better or not. I'm just getting there we go. How's that? Most of us know whether the kids got better because of a medicine or because of something else, because we know what medicine treatment response looks like. So you know, talk with your doctor. If they're on a medicine and they've gotten better, talk with them about what the strategy would be for taking them off, how long they need to be on, all of that sort of stuff. We're used to answering that question. You know, there's a question from a teacher. The Tourette Syndrome Association has so much stuff about schools and education and training teachers and advocacy within school. There's a woman named Susan Connors who's written books about kind of the educational environment for kids with tic disorders. So if you're a teacher and you really care about your kid and you care about other kids in your classroom, there's lots of resources on the Tourette website. How do I treat anxiety into remission? I treat it because it's up here in my head. I want it all gone. And again, because it's not, I don't get rid of normal anxiety. Normal anxiety is what we need to live. I get rid of the separation worries, the general nonsense worries, and the social worries, those pathologic forms of anxiety are the things that I can make go away with medicine and cognitive behavioral therapy. And it should be gone. Kids should look free of that when they're in remission. The complex workup, again, for those teen onsets, abrupt new teen onsets, not worsening in teenage years, but those abrupt teen onsets, they need to see a specialist. And I can't say more than that. They need a really good diagnostic eval. So there was another question about disinhibition. And you know what's interesting, disinhibition is a word that describes the loss of control. So if you think about it, Tourette causes a little loss of control, ADHD causes loss of control, anxiety causes loss of control. We don't have any treatments for disinhibition per se, but we do have treatments for anxiety, we have treatments for tics, we have treatments for ADHD. So what I would tend to do if you've been told your kid's got disinhibition, I'd say, well, disinhibition due to what? And then once you have some understanding of what the disinhibition is due to, then I would begin to think about, well, what treatments treat that thing that causes disinhibition? You know, there's a question about the COVID vaccine and a worsening of tics. This goes back to those slides that I showed about ADHD. Remember, placebo in a person with tics caused 20% of them to have worsening of tics. So you touch a person with a tic disorder with anything, whether it's a vaccine or a stimulant or a placebo or anything, and you've got a 1 in 5, 1 in 4 chance that they're going to get worse within weeks to months right after that happens. So I would say that it's a coincidence, but you know, you can never rule stuff out. But in general, there's a 20 to 25% chance that you take a person who's got a tic disorder and you do something to them that they have a 1 in 4, 1 in 5 chance to get worse. Most of the time, it'll kind of even out and go away, particularly in older folks. Or I mean, in younger folks, or in older folks, it'll go away. In younger folks, it may persist because of the natural course. Okay, here's a question about both Tourette and motor stereotypies. You can use CBIT for both tics and motor stereotypies. The numbers of psychologists who are really good at doing that are few and far between. Harvey Singer and the people at Hopkins put together a kind of a home-based DVD to kind of learn how to do CBIT for stereotypies. So you might want to reach out to Harvey Singer at Johns Hopkins to see if you can get a copy of that. There's a question about being on an antidepressant and they didn't work for anxiety and they caused suicidal stuff. You know, there is, if you look at the product information for these medicine, it talks about being vigilant around the emergence of suicidal thinking. My experience is that these medicines don't cause it, but during treatment, it can emerge. And it oftentimes emerges in kids who are at risk for suicidal thinking in general, because anxiety is a risk factor for suicidal thoughts, as is depression. And so I think that's a very complicated pathway to walk down. So if you've tried a couple of medicines and both times you've tried the medicine and the kid experiences a change in suicidal thinking, it's really important to kind of unpack that and understand whether it was really the medicine or whether there were other factors that were involved. And in most of my experiences, there's other factors involved, but it takes somebody with some skills to do that unpacking and figure out the real cause. So there's a question about genes and being recessive. Recessive means in general that it skips generations. So cystic fibrosis is recessive. One parent has the gene and the other parent has the gene, but neither of them have cystic fibrosis, but they each give a gene to the child, and so the child has 2 cystic fibrosis genes. Those are the kids. That's recessive. Dominant is when dad has it and he gives it to his son. So he has one gene and he gives that gene to his son. That's dominant. What people are thinking about with Tourette is it's mixed, which means it's numerous genes all kind of working together. And that's the reason why, even though there's a genetic component to it, it doesn't predict severity, for example. So you can have all the genetic stuff, but you can have very mild symptoms when somebody else had severe symptoms. 14-year-old needs to be checked for bipolar. That's what the therapist is saying. You can have bipolar disorder at age 14. It usually occurs a little bit later than that, but you can have that. But the hallmark symptoms that were in the slide set, that grandiosity, that over the top, that lack of sleep, that increased goal-directed activity, those are the hallmark symptoms. Those are the things that I always look for to kind of confirm the diagnosis of bipolar disorder. 4 weeks of febrile seizure. You know, there's no real link between febrile seizures and the onset of Tourette later. Just, it's not there in the literature. Could it be a cause? Maybe, but it's not the kind of thing that I think people would hang their hat on. I think they would hang their hat more on genetics and environmental factors otherwise. So my kids' tics get worse when they're sick or they have infection. You know, it's interesting. Some kids actually get nicer and better when they're sick. Particularly ADHD kids often behave better when they're ill, when they have a fever. You know, if you're irritable and cranky and you don't feel well, your tics are going to get worse during that period of time. Anytime you're not able to focus or concentrate, when you're distracted, you're feeling tired, you're feeling sick, your tics are going to get worse during that period of time. Again, late onset tics, you know, they need somebody to do a careful workup. Again, when they're late onset, they've usually had tics as a child, but they were mild. And there's usually something happening at 16, 17, 18, 19, or 20, either stressful life events or the emergence of anxiety and depression in a more severe form that is kind of driving that change in tic severity in those older teens and young adults. So kind of a head thrusting. I'm not exactly sure what that is. Again, you know, there are a few folks on the medical advisory board who are expert, like Doug Woods, who are expert at this habit reversal. There are others on the medical advisory board who know a lot about habit reversal. So it might not be a bad idea to throw an email to the Tourette Association and see if they can answer what a competing response might be for a particular tic. And if you have a therapist who knows how to do CBIT, but they haven't quite figured out what the competing response is, a brief consultation with one of our experts might be the best way to go about that. Skin picking, a competing response for skin picking. Skin picking is a little tricky because it has multiple causes. So sometimes people pick their skin because they're kind of in a dreamy state, they're kind of off task, and so helping them get focused helps. Sometimes anxiety leads to skin picking. Sometimes the skin is inflamed or infected, and that leads to skin picking. There is if all of that has been ruled out as the cause of the skin picking, there is an interesting website called stoppicking.com that is a self-help website that helps people who are skin pickers. It's also a parallel site called stoppulling.com for people who pull their hair. Both picking and pulling are more common in kids with tic disorders. You know, so what if the kid doesn't want to do the CBIT treatment, even though it might help him? He wants to reduce his tics, but he doesn't want to do the work. You know, most really good therapists are pretty good at kind of getting it done. The other thing, though, is that I do a lot of this work with parents so that parents begin to learn how to do it and how to implement it at home with their kids so that the kid doesn't get exposed to the therapist. One of the things that kids know about themselves who have tics is that if they talk about their tic, they may tic a little bit more. And that's a bit of a hurdle that a good therapist can kind of overcome and begin to work on with that young person. And sometimes the therapists, you know, when I talked about the kid with the tongue thrusting, that took 2-3 minutes to work on. You know, and some therapists take too much time to get to it. So having an efficient therapist that focuses on a really important tic for your son that he wants to get rid of and do a simple set of exercises, that can take 15 to 20 minutes. It's not a 10, 12-week therapy. It can be very quick. And that might make it easier for your son to get over the hurdle and get more invested. Yes, I do use the term competing response when I talk about tic management. You know, there are many kids who don't pay attention to their tics. You know, one of the truisms about Tourette syndrome is it tends to bother parents more than it bothers the kids. And you know, that it's hard to when that's the case, I tend to kind of go with the kid, unless the kid is in denial, you know, that the tics are pretty bad and they are getting in the way, and the teacher's saying something, the other kids are saying something, the kid just wants to be left alone, and he says, don't bother me, leave me alone. I'll work with those families and kids to engage that kid and to get him to participate. Oh, so there's another description of habit reversal. An older adult who participated in habit reversal treatment. So some of the competing response that I've seen therapists use are kind of wrong-headed. And what I mean by that is I think about white knuckle tic suppression, which is like, you know, you tense every muscle in your body. All that does is add stress and makes tics worse. The point of a competing response is to outsmart the tic and to put your brain in that kind of calm, focused, mindful place. And so what this person is describing in their question is, on some level, they were trained to do white knuckle tic suppression, which didn't work for them very well, but now they're working on something that's a more mindful, focused kind of attentiveness to their tic, and they find that that works a little bit better. So it really is a combination of a competing response, but being implemented in a calm, focused way that really is key to the competing response training. We don't necessarily need to have that premonitory urge before the tic in order to do CBIT. Sometimes there was a kid we saw a demonstration of who had a vocal tic, and what he did was he put his hand in front of his mouth before he ticked. So he had a woo sound. So he went woo, woo. And so he didn't have a premonitory sensation, but what was interesting is he moved his hand before he wooed. And so what the therapist said is, pay attention to your hand, don't pay attention to your woo. And when your hand begins to move, begin to think about doing your diaphragmatic breathing. So even though there was no premonitory sensation up here, there was something happening in his arm that he could clue in on and begin to do the diaphragmatic breathing in order to interrupt the tic process. One mom talks about escapism as a way to kind of deal with their kids' suffering. And you know, this is tough. What we're talking about, that flipping from being empathic to your child to finding a way to empower your child to take on their challenges, that's a tough transition for some folks. And there's some kids who are going to fight back. They're not going to want to do the thing that makes them uncomfortable or is hard for them to do. It takes some real work. So you have to do a variety of motivational strategies and rewards and all kinds of stuff to get a kid to kind of say, listen, you got a problem. I wish you didn't have it. But you know what? If we work together on it as a family and we kind of see the light at the end of the tunnel, and we engage in therapy, and we do all the right stuff. We're going to take you out of this difficult place, but we need your help. You need to kind of join up with us. So it's a lot of work. If you don't have that kind of momentum going, then you're going to be in the position where you're going to avoid and accommodate, and you're going to kind of get into patterns of behavior that actually are going to make things worse. Oh, how do you do competing response with a kid who's oppositional and defiant in general, and they don't want to do anything? Yeah, that one's tough too. But if you think back to that parenting bit that I gave you, that oppositional behavior is power struggle stuff, right? And so the way that you get rid of power struggles is by having a structured routine and a plan for the day. And you essentially look at when those power struggles develop, and you develop a sequence of behaviors of productive activity during those periods of time when kids are most oppositional. Many parents like to tell their kids what to do. Time for this, time for that, do this, do that, do this, do that. That approach to parenting is reactive and essentially trains the kid to not listen and is annoying and leads to oppositional behavior. So the way that we counteract that is for kids to have a very powerful, strong, well laid out daily routine that has tasks in it and that has rewards, tasks and rewards, tasks and rewards. And if the kids are doing what they're supposed to be doing and they get rewarded for doing that, they stop really being oppositional. They are oppositional when do this, do that, here you go, there you go, do this. That's the kind of interactional style that many modern parents get into with their kids that actually facilitate the development of oppositional behavior. So I would be working on oppositional behavior first. Then once you get that under control with some good parent training, then focus on engaging the young person in CBIT. We've done CBIT in 8-year-olds, and it can be done, but it takes an 8-year-old who's kind of ready to go to work a little bit. Sometimes a parent and a parent coach could be helpful. I talked about the 6-year-old. I did the one competing response with the tongue thrust. If it's a single tic that you're really working on, you could probably do that for a single tic with a very young child. Teach them the tricks and get them using those strategies. Oh, there's one family that is having a controversy about whether the kid should wear a T-shirt that says "I have Tourette syndrome." I like kids to have an identity around being a good student, a good athlete, a good family member, a good musician, a funny person, a good joke teller. I'd rather have them an identity around a million other things other than Tourette. So, I might ditch those T-shirts. Oh, this is a good one. So this is okay. So I'm doing my competing response training at school. How am I supposed to learn? Well, so here's the deal. I actually talked with a 16-year-old, and I said, listen, you've gotten very good at this competing response training. You really knocked down the severity of your tics. Tell me about what it's like at school, and how much does doing the work at school, kind of the competing response stuff at school, get in the way? And he was like, what are you talking about? Do you know what it was like before? And I said, tell me. He says, I sat there, I was ticking, I didn't know what to do. Everybody was looking at me. I was self-conscious. I couldn't focus. I was so uncomfortable. I could hardly wait to get out of the classroom. What I do now is I do my diaphragmatic breathing, and I hold my arm to my side so my arm doesn't flap. I'm not ticking. I'm not self-conscious. It's uncomfortable. I'm working on it, but I'm able to pay attention. I am so much happier now doing my competing response training at school than I was before when I was self-conscious, I was upset, I was ticking, and the more upset I got, the more I ticked. Now I'm in a much better place. Yes, I got to work at it at school, but it's not like what it was like before. It's so much easier now. So I think that's the frame that we need to use when we talk to kids about engaging in CBIT in those other environments. Non-U.S. citizen get parent training. Parent training is universal. It's everywhere. You just have to find the right therapists who know how to do it. Oh man, there's a very complicated one here about complex syndrome of seizures, Ehlers-Danlos, and other stuff. You know, this is one where it's hard to advise. The PCP is a little confused about kind of how best. This one requires a team meeting. This one requires a team meeting of the specialist to kind of identify and prioritize the conditions that need treating. Oh yeah, so here's one. My kids learned how to do CBIT, but I remind him to do CBIT when he's ticking. You know, there's nothing children hate more than being reminded by their parents to do something. So this is why, remember when I talked about the 6-year-old, I said, don't tell him to do this, just do this. Kids get annoyed when parents say things to them, and that's this whole power struggle business. So what you really need to do is you need to have a hand signal or something that's nonverbal. So when he's ticking, you do something loving, like that cues him to do it without embarrassing or humiliating him or correcting him. Kids hate that stuff. And so you will get oppositional behavior to treatment, which is what you don't want, because you're using verbal strategies to remind. Oh my gosh, that was bizarre. Okay, so don't verbally correct. It ends up turning into a power struggle, which is what you describe in your question. Use some other hand signal or something and work it out with your kid how he wants to be reminded to practice his habit reversal stuff. The other thing is you can practice habit reversal in specified times of the day where you can interact with him around it, you know, like a coach, but don't do it all the time during, you know, at various times and points of the day. Save it all up and do it in kind of specialized blocks of time. That way the kids won't get annoyed when you try and correct them. So here's the question about tics, just to be clear. If you don't have tics and you start a stimulant, you have a 6% chance of getting tics on the stimulant, and you have a 6% chance of getting tics on placebo. If you already have tics, you have a 20 to 25% chance of having worse tics on clonidine, a stimulant, and placebo. Essentially what I'm saying is tics wax and wane. They increase when somebody does something new or different, or they're thinking about something, or there's some kind of disruptive thing. Even the COVID vaccine, for example, could be a disruptive thing that takes existing tics and makes them worse for a period of time. The issue is it's not the medicine, it's the nature of the condition, that anytime you disrupt the flow, whether it's a new medicine or a new environment or a new whatever, you can see worsening as part of that process. Are there any natural stimulants? I've had some families use caffeine as a natural stimulant, but you know, most of those natural stimulants aren't as potent as the pharmaceutical grade ones. And so if you really are trying to do something and be effective and get on top of some of this stuff, use treatments that work. Use treatments that have been proven to be effective. Again, how do you explain a person who gets Tourette at the age 20, 25? I've talked a little bit. I'm going to do it one more time. Late onset tics like that deserve a full and complete evaluation. The vast majority of those late onset cases had tics when they were much younger, but they were mild, and that there is something happening now at age 20 to 25, anxiety onset, depression onset, substance use if it's a college student, stressful life events, any number of things that we know make tics worse can cause tics worsening in a person who already had tics. for a person where we know for sure that they never had tics earlier, adult onset is beyond rare and needs a full workup. You know, kids who have Tourette and who have been abused and neglected, they just have extra challenges because abuse and neglect undermine kids' capacity to grow strong and solid and mature, and to be able to have those characteristics that they can use to take on that extra disability, that extra challenge of Tourette. So, you know, it feeds into the inability for kids to kind of do their best in life because they've been abused and neglected. It's not causal in the sense that that question may imply, but it certainly makes life difficult for a person with Tourette. You can really have remission from anxiety? Yes, you can. Yes, you can. You can make it all go away, but it has to be the syndromes of anxiety. Panic disorder in adults, separation anxiety, social anxiety, and generalized worry. Those are the disorders of anxiety. They are exquisitely responsive to treatment. 65% of kids in 12 weeks with CBT and good med management go into remission, no symptoms or few symptoms. So yes, it's a lifelong condition potentially, but you can put people into remission with good treatment. Yes, so what do we do about an environmental trigger for a tic? This is that thin stimulus barrier. So coprolalia that's triggered by some kind of sound in the environment. So awareness training is the first and most important thing. The second most important thing is that the habit reversal strategy for coprolalia is diaphragmatic breathing. So you want that person to get really good at looking out into the future and seeing where those triggers are, getting way ahead of themselves, getting in charge of themselves, becoming more mindful and aware so that they know the world they're living in. If they see the trigger coming, go into diaphragmatic breathing so that they can manage the coprolalia. Kids who are impulsive are going to have more power struggles. If kids who are impulsive have more power struggles, they're going to develop more behavior problems. If they develop behavior problems, they're going to get rejected more frequently by peers. Kids who are impulsive, like with ADHD, are more difficult to parent. Parents who don't really have those industrial strength parenting skills are going to have a harder time managing their kid with ADHD and who has impulse control problems. They're going to have more power struggles. They're going to develop more behavioral difficulties more quickly. So again, getting on top of that by getting your parenting skills really tuned up is really what you do when you see that your kid's got a vulnerability like anxiety or depression or ADHD or a tic disorder. I hate to say it, but you have to be extra good as a parent in order to really be effective with kids who have these kinds of vulnerabilities. So how do you end the power struggle? So my examples sound like my household. I've been told, I've been asked whether I was at somebody's house last night because that's exactly what happened with Billy, was happening at home. And so what you do is you take your expectations in space and time and you embed them in a daily routine and you get into what I call the secret of life, which is you work, there's someone who pays attention to you, looks you in the eye and says, job well done, and you get rewarded. That work, reward, work, monitor, reward, work, monitor, reward is essentially what takes expectations out. I'll give an example. So a lot of kids get up in the morning now, go downstairs and they eat breakfast and then they turn on the Nintendo and then the parent comes down and says it's time to get dressed. If you think about the sequence of that, the kid gets up, he fills his tummy and he plays a game and then the parent says, got to stop that now and go get dressed. What we do with that kid is we say, you get up, you go to the bathroom, you get dressed, you leave your room ready for the day. When you come into the kitchen on time, and if you're on time, you get a thumbs up from the parent and then you eat breakfast. So you work, you get monitored, and you get rewarded. What we've done in the United States and in many other places is we reward children and we cross our fingers that they will do what they're supposed to be doing because they've been rewarded or gratified. But the way the world really works is people work and then they get gratified. So what we do with traditional parenting is we set up a structure where the expectations are embedded in space and time. where there's a parent there to monitor or pay attention. And then when the kid completes the task on time, they get a reward. So when I flip that morning routine around, what tends to happen is the kid actually goes through their morning routine faster. They come into the kitchen earlier so they can have more time with the reward. If I tell a kid, come here, he's going to resist and fight back. If I stand next to the kid and I say, I'll race you over there, he will beat me there every time. So what we try and do with kids' daily routines is we try and put into place where the things that they have to do, they do, knowing that if they complete them in a timely and efficient way, they get access to a reward. Then they do another set of tasks in a timely and efficient way, then they get another reward. And so we build the whole daytime structure to work, reward, work, reward. Most schools are built that way. They work for 2 hours, have recess, work for 2 hours, have lunch, work for 2 hours, do art and music. My job is like that. I work for 2 hours, I have a cup of coffee, I work for 2 hours, I have lunch, I work for a couple hours, and then I blow off some steam and have fun with my employees later in the day. Work, reward is how you end the power struggle. Embed those expectations into space and time.
Okay, Dr. Walkup, just to keep you on track, we have about 15 minutes left for the session.
For the whole session.
Yes.
Have you gotten more questions?
Yes, I can email you another set if you like.
Yeah, why don't you send me another set, as I'm almost done with this set.
Okay, will do.
And then everyone, as Barbara is sending the last set of questions over to Dr. Walkup, I do just want to chime in and say, thank you so much for tuning in today and for all your incredible questions and comments. And if there are questions we were unable to get to today, we will do our best to either follow up with you, or you can send us an email at support@tourette.org and we can directly follow up with you to make sure that you get the responses.
So there's another question about CBIT and a toddler. Some toddlers will develop tics, but I think more important for me with a toddler, rather than trying to do habit reversal, is really to build that tic-free environment where you're not paying attention, you're working with that kid to manage their emotions and behaviors. And for toddlers, it's really simple. It's learning how to fall asleep, it's learning how to eat, it's learning how to toilet, it's beginning to learn how to control emotions and behavior in a toddler. If you're working on all of those things with a toddler who's ticking, you're going to set the stage for overall good growth, psychological growth and development. And as the kid gets a little bit older, you'll be able to do the CBIT. This is one of my favorites, forgive me, but a neurologist told me that CBIT can backfire, and that focus on suppressing tics can actually cause more anxiety and stress and actually worsen tics. The data does not support that. Sorry. Really sorry, the data does not support that. That is old thinking, and that's why what I said today that I was going to do is bring you up to date with the new thinking about stuff in Tourette. And we have people who are trained at different times, different places, different eras, with different understandings about what Tourette is. And what I tried to do was to bring you the latest and greatest, and that's an example of old thinking. Sorry. Last set of questions, 15 minutes to go. Can I weigh in on Tic Helper? Tic Helper costs $150. Are you kidding? Probably cheaper than a psychologist or a psychiatrist, but that's built by people who know what they're doing. So it might be $150 well spent. It's kind of tailored after Stop Picking and StopPulling.com, and it's done by really good people. So no guarantee. It is $150. Yeah. Maybe they have a money-back guarantee if you don't like it or you're disappointed. Okay, a 17 and 18-year-old who's got oppositional behavior but not Tourette. It's never too late to change oppositional behavior. And you know what? with those 17 to 18-year-olds, you still have a lot of control over their life. You can pay their car insurance, you give them a credit card, you can buy them clothes, you can help them fund their apartment. You can do all kinds of things with a 17 and 18-year-old because you still have opportunities to engage them in problem solving around their behavior, because you oftentimes provide a lot of financial and emotional support to those kids. So yes, I do parent training with parents of older teenagers and young adults. It can be very effective at that age. Do you do, just as a, you know, a trial, antibiotics for a month when somebody first shows tics? Probably not. Probably not. Would I blame somebody for doing it? No. Would I do it? Probably not. The new treatment paradigm, you mentioned parent training for children under 9. Where is this training offered? You know, parent training, you can read it in books. Sometimes they have parent training classes at the YMCA or community centers. Sometimes therapists will do parent training. But you know, some of the books at the end that were in the slide set, those books are all about parent training. Will an MRI, you know, address the issue of an ongoing infection? Oh, that's a tough one. Very specific case. I can't really comment on that, where an MRI identified some kind of infection. Usually MRIs don't identify infection, but so any kind of infection that would get identified by an MRI is probably a pretty serious infection. Oh my goodness. You know, so what's the competing response for the raised middle finger? Putting that hand in a pocket is probably the most important thing for that person to do. The other thing is that there are some families that can confuse by raising that middle finger out of anger and raising that middle finger as a tic. And when that middle finger gets raised as a directed activity towards a person or experience, there's a lot of volunteerism in that, not so much ticism in that. So I would be careful about kind of how that one gets managed. Oh, pushing on eyes, difficult. Again, those are managing where those hands go, and yeah, that probably takes a pro, someone who can really dismantle that behavior, figure out where the triggers are, where the environments are, what the competing response is going to be. That's not one for someone to work on at home. Neck cracking, you know, that again, that's the kind of thing that you're going to look at what causes it, when it occurs, why it occurs, all of those kind of surrounding environments. You're going to create an awareness of it, and then you're going to work against it by doing some alternative behavior. And again, a diaphragmatic breathing can work for almost any tic, not just vocal tics. So for some of these tics, just when the feeling is there to crack the neck, if they were to do diaphragmatic breathing, some therapists might recommend something like that. Again, if kid refuses CBIT, you've got to work on the motivational side, and sometimes working on a single tic in a very brief way, like I did with the tongue thrusting, is the way to get kids started. A large uptick in Tourette. You know, stress causes increase in tics, and so many kids who had mild tics that were unrecognized, under the pressure and stress of tics, they may flare. But also there's a whole variety of this adolescent onset in girls tic business is probably a different kind of movement disorder than a tic disorder, and I wouldn't want to call that Tourette. That's why I called it TikTok tics. It's something else. It's different than traditional Tourette syndrome in terms of when it onsets, who it affects, kind of what the patterns are of behavior. Significant worsening post-puberty. Again, you got to be thinking about something like TikTok tics. But again, if the kid had tics earlier and they're worsening in adolescence, I would look for worsening anxiety, worsening depression, worsening situational stress. And if there weren't tics earlier and there's an adolescent onset, I think that requires that full workup. There are kids that play with themselves in public in a sexual way. Again, It can be a tic, but sometimes it's just self-stimulating or soothing behavior. Sometimes just a kind of gentle correction. But also it's the kind of behavior that you can outsmart by kind of figuring out when it happens, where it happens, and beginning to work with the youngster to prepare and manage that in advance. It's not the kind of thing that once it starts happening in public that you can actually intervene in that moment. You have to get way ahead of that behavior, outsmart it, if you will, by having a preparatory plan. There's a question about fingers and toes that I don't quite understand. So give me some more details on that one. Oh, you know what? It's really interesting, this whole genetics thing with Tourette. There are kids who don't have a parent with a tic at all. And so about 25% of kids with tics don't have a parent who have tics or OCD. So, you know, they may have low-grade genetic stuff and it combines and the kid presents with a tic disorder, but not every kid has a parent who has something. So whether it's in vitro or something else, they're probably still driven by genetics, even though no parent is particularly affected. Some
Dr.
children
Paul, we have about 5 minutes left.
Okay, I think I'm getting there. Some kids do have a challenge with handwriting. You know, kids with Tourette are neurologically vulnerable, and so they will have trouble with motor coordination and other kind of stuff. So physical therapy, occupational therapy can be useful for kids with that kind of stuff. Belly aches in a kid with Tourette who's 10 years of age makes me think about working them up for an anxiety disorder, particularly if they have troubles falling asleep and they have other symptoms of anxiety or worry or fear. Best treatments for anxiety disorder in an 8-year-old is cognitive behavioral therapy for anxiety. The manualized treatment is called Coping Cat. So if you look on the net, you can read about the Coping Cat. And then the medicines are the Prozac, Zoloft, Luvoxes, escitalopram, Lexapro, those medicines. Cymbalta is another one. Yeah. Oh, golly. A very complicated teenage young person who's got lots of different diagnoses. And, you know, trauma has a very specific impact on people and their symptoms. And the outcome for trauma, the natural outcome from trauma is recovery, complete recovery. If you look at the number of Vietnam veterans who have PTSD, it's only about 8%. So the 92% of veterans who went to Vietnam don't have PTSD. So, and if you look at that 8% of veterans, they have a history of anxiety, depression, substance abuse, neglect, poor educational attainment. They are a very complicated set of human beings. So PTSD, the reason trauma persists is usually because it sits in a place where there's anxiety, depression, or other issues already, because vast majority of people recover from trauma. So when I hear about traumas causing everything, I kind of think, yeah, it may be causing some stuff, but it usually causes a very specific syndrome. And it's usually the other things that allow trauma memories and trauma experiences to perpetuate themselves. Specialist for teen onset would be some multidisciplinary program where you would have a sophisticated neurologist who understands Tourette syndrome and also understands psychiatry. So a psychiatrist who's worked with medical problems in general. Not just an ordinary psychiatrist, but a psychiatrist who sees a lot of kids with complex medical problems. Are stereotypies swimming? No. Paralysis tics, you mean kids freezing up with the tic, like getting stuck in a posture? That's a more complicated movement problem. Tough to know exactly what you mean by that. Can your eyes watering be tic-like eye blinking is? Don't have an answer for that one. You know, the other thing is if you have concerns about a 9-year-old who's got a couple of symptoms like, you know, behavior problems and ADHD, and maybe they start ticking, you know, you want to get ahead of this. You don't want to wait or kind of just watch and wait. You kind of want expertise to be up front. The other thing is that if you call for an appointment now, you might wait 3 months. So call for an appointment and you could do your watching and waiting for the next 3 or 4 months and then get your appointment. Get on top of this stuff faster. You know, the best way to find a CBIT provider is to call the Tourette Association. Oh, I got somebody like the talk today. That's good. You know, there are kids who chew on their T-shirts, who suck their hands, cause stuff. All of these are kind of habity things, and they would be habit reversal might be the treatment of choice for that youngster who sucks on his skin. And as far as I know, there's no correlation between tic disorders and IVF. Are electronics related to tics? So when kids are doing really in the game and they're calm and focused, their tics go away. When they get to a new level or a new challenge or they get disappointed, their tics flare up. So you can see both with electronics. Long flights in an airplane where a kid gets tired, cranky, and irritable is going to definitely make tics worse. So you practice your competing response, your habit reversal, your CBIT exercises before you get in the plane. You practice them on the plane. You manage your tics as best you can on the plane so that when you get off, you're in a much better place. You plan ahead to use your strategies. If you have anxiety and Tourette, what do you go for first? I tend to go for the anxiety first. I'm a psychiatrist. I also think that anxiety improves a child's quality of life quite dramatically, including educational functioning. So I go after that first before I go after the tics. The competing response for any kind of eye blinking would be that slow rhythmic thing that was on that slide. Can olanzapine cause tics? Again, any medicine at any time can be associated with a 20 to 25% increase in tics. Probably not the medicine, probably the waxing and waning, the natural course of the tic disorder.
Dr.
Is there any benefit? Are we done?
Yeah, we actually ran a little bit over, but thank you so much. And to everyone.
I think I have 3 questions left.
I'm sorry, you have 2 questions left?
Yeah, just a couple. There was one about an adult. Do I need a diagnosis if I'm an adult with Tourette? You know, if you look up Peter Hollenbeck, and the Tourette Syndrome Association has a narrative of his life history. Peter's on the board of trustees and is a professor of neuroscience at Purdue. He had Tourette all his life, but didn't get diagnosed until an adult. And he tells about the value of the diagnosis to him and how he was managed as a kid. It's a terrific story, and it's available. I think the Tourette Syndrome Association should have it, but it also might be available on the net. Peter Hollenbeck. He wrote his own kind of life story about being diagnosed as an adult. Worth reading. I'm done.
All right, great. Well, thank you so much, Dr. Walkup, for such an excellent presentation. And everyone, thank you so much for being so attentive and sticking with us and asking so many great questions. I think everyone's questions, I'm sure, helped each other. So thank you so much. Again, if there was anything we weren't able to get to, you can write to us at support.org and we will follow up with you directly. And then just know too that this was recorded today. So you're going to receive a follow-up email within 24 to 48 hours with a link to view a recording of the webinar, which we will also post on our YouTube channel for those who are unable to join us today. Thank you so much again. You will be notified of a survey right after this. If you don't mind filling it out, it will help us so much to guide our future presentations. And again, this was offered free of charge thanks to our generous donors. And thank you so much for your support. Have a great day, and thank you, Dr. Walkup.
Thank you, guys. My best to you all.